Give folks a minute here. Welcome in. Can you hear me? So I forgot to test my microphone before I went live. Looks like it's working. Let me know if you can hear.
I see.
Respond, did she send you some additional messages on my chart, if you remember? Or if you could look at your notes.
Okay. I see that the symptoms of depression that she reported.
Yep, so just drawing your attention to 12:58 p.m.
Yes.
You get another message from her where she says, the symptoms of depression that are much worse are just feeling completely hopeless and unmotivated to do anything at all. And that she says, I printed the daily mood chart and we'll start it. Now, you said that you did ask your nurse to give her a phone call at some point, and so you're aware that a nurse did call her on November 30th at approximately 3:10 p.m.
Yes.
And that during that phone call that Lindsay agreed to the plan and that she was going to pick up the Seroquel.
Yes.
Okay. Now, at that point, you had another meeting scheduled with her for a week out, right? Mm-hmm. But yes. Prior to that, did you also continue to communicate with her via my chart?
Yes.
So moving into December 1st, again, were you able to send her a message?
She sent me a message on December 1st, and I did reply to it.
Okay, so December 1st at 12:20 p.m., we have a message from Lindsay Clancy. Hi, Rebecca. I really don't like the way I feel on the Remeron, and I know that I can't stick with it, or I can't stick with taking it. I started having very intrusive thoughts that I never had before. I didn't take it last night. I would really like to go back to Julie's original plan of Prozac in the morning and using Ativan and Benadryl at night as a Band-Aid until I get to a therapeutic level of Prozac. Please let me know if you agree with this plan. I know that I need to give it a good couple of weeks to work. Is that the message that you first received on December 1st?
It was.
And were you aware that that same day that Lindsay had reached out to her primary care physician asking for an immediate appointment with her nurse practitioner?
I was.
And that she was looking to discuss medications?
Yes.
Do you know if she actually got an appointment or went to the appointment there?
They had reached out to her, and she did not respond to their voicemails or my chart messages, so she did not see them that day, to my knowledge.
So you're able to review the notes from the network of South Shore Health, right?
Correct, yes.
So you were able to review that she asked for an emergency appointment. They were able to find her an emergency appointment, but she didn't get back in enough time to actually get there.
Correct.
Okay. And so in the meantime, you're having a back and forth with her during the course of that day, December 1st.
Yes.
When she indicated to you in this message on December 1st about having intrusive thoughts, and not liking the Remeron and not taking it, what was your response?
I sent her a detailed message of signs and symptoms of postpartum depression and anxiety, including factors like onset, risk factors, predictors, common symptoms, and it highlighted how intrusive thoughts are quite common in postpartum depression and anxiety, and I asked her, I'm wondering if that's what's going on here. I then asked her if she was able to take the Seroquel that night and if she noticed any improvement in terms of sleep or anxiety with the Seroquel.
Now, by giving her this information about postpartum depression and postpartum anxiety, was that consistent with a diagnosis that either you or Julie had given her in coming into the clinic?
Yes. We were thinking this could be some postpartum anxiety, and I wanted to familiarize her with the symptoms so that she had them written down and she could report them to me and understand that they are part of these disorders.
Okay. And you also gave her some information about obsessions and compulsions, right? Mm-hmm. And you said you asked her about the Seroquel and asked about sleep, right?
Yes.
And did you also reiterate that you were still encouraging to keep up with the Remeron for a period of time?
Yes.
And you further indicated to her that you wanted to kind of see if there was a correlation between the symptoms and the medication and that you just didn't have enough data.
Right.
In response to that message, she actually responded at 2:36 on December 1st, correct?
Yes.
And she indicated, thank you for the information, it was helpful. That she says, I panicked last night and just took Ativan and Benadryl, but tonight I'll stick with the plan and try the 15 of Remeron and the 25 of Seroquel. Do you recall if you had ever had a conversation with her about kind of using Ativan and Benadryl as a backup, or?
You know, one of the things about, she started seeing her like a month and a half after this other doctor who doesn't know a fucking thing. She's got more history, more knowledge, more communication, more documentation with Lindsay than her own damn doctor.
If she just felt like she wasn't getting any relief?
I recall having a conversation about using the Ativan as a backup. I believe it was, yes, in my initial, I said continue the Remeron and the Ativan as needed.
Okay.
Yeah.
And what about the Benadryl?
The Benadryl I don't recall discussing.
But you were aware that she had reported the combination of Ativan and Benadryl had worked for her before.
Right.
And in that message, she also says, I'm sorry for all the messages. It's just a scary, very scary, stressful time for me. And starting new meds with side effects is very scary to me. I'll check in the morning and let you know how it went, right?
Right.
Okay. And again, you continued to have some contact with her on that same day after that.
I believe I responded to that, reassuring her that it's understandable to have fears, concerns about starting medications, and I sent her a detailed description of common question and answers I get from patients about medications, things like what to expect, how long does it take to work, what are common side effects, risks for, is there any risk for suicide, homicide with medications,
So in providing all this information with her, what were you trying to do?
Provide information because she had said it was so scary starting medication, so I wanted her to be equipped with understanding and what to expect possibly.
And based on your interactions with her and your review of Julie Paul's interactions with her, this was a person that was very receptive to taking information, right?
Yes.
And as her role as a nurse, she was not afraid to ask questions. Is that fair to say?
No. Yes, she was not afraid.
And one of the things that you provided her, or the information you provided her in this detailed response back to her on December 1st at 3:04, was that there are other sources or resources that she could utilize that are available at the clinic, right?
Yes.
And
go ahead.
show you these two books, Exhibit 148.
Yep.
Good Moms Have Scary Thoughts, and this one, The Pregnancy Postpartum Anxiety Workbook.
Yes.
To you?
Yes, I instructed her that we had copies of these books that we were giving out to patients and that she should come grab them when she was in clinic. And she informed me she would be seeing Letitia the next day for counseling, so she would grab them when she was there.
Okay. And so that day, December 1st, fair to say you went back and forth with her from about 12:30 to her last message, she was at 4:37 that day.
Yes.
And you said that she indicated that she did have an appointment the next day with Letitia Dukes.
Yes.
And were you aware of whether that was an in-person meeting?
Yes, it was in person because she said, I'll be in clinic, I'll be able to get those resources.
Okay. So moving to December 2nd, you didn't have a scheduled appointment with her, correct?
I did not.
And you knew she was going to see Letitia that morning in clinic, right?
Correct.
And you received several messages from her that morning.
I did.
Again, through the MyChart portal?
Yes.
Beginning at 7:51 a.m., where she sends you a message saying, "Hi, Rebecca. I took the 15 Remeron and 25 Seroquel. I woke up at 12 with horribly intrusive thoughts of wanting it to be all over. I took 1 milligram Ativan and went back to sleep, and the thoughts went away. Now that I have the Ativan on board, I really need to explore the option that I'm addicted to Ativan. I have a therapy appointment with Letitia in your office. I would really like to speak with someone in the substance use clinic to explore the option."
This... knowing how addicts behave, I don't... Who is telling her she is addicted to this? I don't see it. I don't understand the fear. I mean, the dependency on it to fall asleep, I get, but an addiction? And her husband had said that he didn't want her to get it. Like, in the one testimony, it was the husband who didn't want her on the Ativan. Hi, Mary. I just don't see why she would feel that she was addicted to Ativan. That's her husband's feeling, according to a testimony of a doctor. That's interesting, because I don't see it. I could see her being in fear of having to rely on it, but she just got it. She's a nurse. She just got put on it. You're not getting addicted to Ativan that fast. I don't see it.
Do you recall getting that message?
I do.
Okay. And did you respond to that message?
I did. I am credentialed at Cellshare Health and Addiction Medicine, so I felt that I could be that person to discuss those concerns with her.
Discuss the substance use concerns?
Mm-hmm.
And so, and you're aware that the social workers can also screen for those as well?
Yes.
So at 8:51 on December 2nd, you respond to her, right?
I did.
And what do you tell her about the concerns she just expressed in her 7:51 message?
I fully appreciate and understand the concern for benzo tolerance. It's not something I want to happen to my patients ever. That being said, there's a place for benzodiazepines, especially at the beginning and acute phase of treatment and getting someone stable. And then we would always pull back slowly. I think another thing to try tonight would be to take 50 milligrams of Seroquel, the 2 tablets, and see if that works better. The intrusive thoughts are part of postpartum depression, anxiety, very painful to think and experience, but I want to reassure you that it's not uncommon and mean nothing about who you are as a mother. Let me know what you think.
And so the recommendation from 25 to 50 milligrams of Seroquel, is that still within the range for treatment for insomnia?
Yes.
So would you characterize that as a low dose, a high dose?
A low dose.
And as far as her statement about intrusive thoughts, fair to say your response doesn't ask her more specifics about those thoughts, right?
No.
But you reiterate to her, just as you had in the lengthy messages where you provided information, that intrusive thoughts are pretty common.
Correct.
Now, did she respond to that message?
She did.
And so at 9:04 on December 2nd, there's a response from Lindsay Clancy. "I'm willing to try anything. I just keep coming back to the feeling that I'm dependent on Ativan after my 2.5 weeks of taking it daily with Benadryl.
That's not even a rational thought for a nurse. I'm sorry, what? That shit is being told to her by her fucking husband. I'm telling you. It's already been stated by a doctor that Patrick was the one in fear of her being addicted to Ativan. And 2.5 weeks? I could just imagine this, like, shit being said by my ex-husband. Like, I just keep... These are such familiar phrases and behaviors. That is such a fucking... That is not even a rational thought for any nurse. 2 weeks? Nah. That's her husband speaking right there. That is her husband coming out of her mouth. That's exactly what that is. This is a manipulated fucking woman. And you're not going to convince me otherwise. You would have to have, like, a plot from, like, Getting Married and before. There ain't no way.
Following the bad reaction to Zoloft, I feel addicted to it, and I feel like I'm not being heard that is a possibility. I feel like we are throwing all these different meds at my insomnia when the root cause is Ativan dependence. I don't feel any of the anxious thoughts I had before. I feel completely numb. So you got that message from her at 9:04, correct?
I did.
And what was your concern when you got that message, or did you have any concern?
I wouldn't say I had concern. I just wanted to, again, provide her some information about what I thought might be happening.
Based on your training and experience as a psychiatric nurse.
Sorry, she didn't finish her answer, please.
Okay, yep. Go ahead.
I was finished.
Okay, well, she's finished. All right, next question.
Based on your training and experience as a psychiatric nurse, and you said you had some experience with substance use, did you feel that there was a dependency issue or an addiction issue with Ativan?
I did not.
Is it fairly common that Ativan is going to make somebody feel better if they're feeling anxious?
Yes.
That's why you take it, right?
Yes.
And that's why you take it as needed. Is that fair to say?
Yes.
So, in your response to her at 9:37, do you make clear to her the difference between...
There's something missing here, which is an assessment of need. So, like, when you call for a PRN pain med, are you calling every 4 to 6 hours around the clock? Then that med should be fucking scheduled. You know, like, there's a lot of context being left out about how we do things in healthcare. We do an assessment. If that medication is ordered PRN, for those not in medicine, that is as needed, and you have to call for it. There's a lot of people that get mad that nurses don't offer. We're not, we are not allowed in healthcare to offer you your PRN med. You have to ask. It's as needed, as you want it. You got to ask. But there's an assessment of need. Pain scale, you know, how often are you having to take it? If you're having to take it every day, well, then that's as needed is a little bit, you know, like there's a lot of context missing here, prosecutor. This is why you're getting called out by TikTokers. And they're being asked to testify and shit. Like, what?
Dependence and addiction?
I do.
Okay. And as far as benzodiazepines go, there's a real concern for dependence and addiction in the fields. Is that fair to say?
Yes.
But based on taking it for 2.5 weeks, taking it to address...
Do you notice how they also only cherry pick her nursing background? They don't give her credit, like, shouldn't she know this? They don't bring that up right now. They don't dare bring that up because that would be like, okay, this is not a rational thought for a nurse, right? Right. But they'll sure discredit her in other areas like drug seeking. Pay attention.
Actual symptoms of anxiety? Did you have a concern of dependence?
No.
And so did you articulate to her that anything about that concept of dependence versus addiction? What did you say?
I I said, I wonder if you fear you're becoming dependent on the benzodiazepines, and there's a subtle difference between dependence and addiction. With addiction, there's a change in behavior caused by biochemical changes in the brain after continued substance abuse. The substance use becomes the main priority of the person with the substance use disorder, regardless of the harm it causes to themselves or others. With dependence, we're referring to physical dependence on a substance characterized by symptoms of tolerance. Characterized by symptoms of tolerance and withdrawal. Benzodiazepine withdrawal is similar to alcohol withdrawal symptoms. We would be seeing things like elevated vital signs, high blood pressure, tachycardia, diaphoresis, mild alteration of mental status, initially with a possibility of perceptual disturbances, delirium, dysphoria, and tremors. Did the insomnia predate the Ativan use? I hear your concerns about the benzos. So my recommendation is do not take them every night. I recommend taking only every other night, and then we will not refill it.
And so what's diaphoresis?
Sweating.
Okay. And in the fields of prescribing psychiatric medications, do you often have to deal with physical dependency and then addressing it later?
I wouldn't say often.
Is there a way to address that as far?
Absolutely, yeah.
And so that wasn't a concern of yours regarding Ativan, was it?
Not at that time.
And what about her statement about not being heard? Did you see that in her message? Where she says, I feel like I'm not being heard about addiction.
What is the number one thing that I tell you about people when they get upset, when they get frustrated? It's because we're not being heard, or we feel like we're not being heard. And this is exactly her complaint. I'm not being heard. I'm not being heard by my provider. I'm not seeing results. I'm not feeling relief.
That being a possibility.
As a psychiatric nurse practitioner dealing in psychiatric medicine, is it important to you when a patient tells you that I don't feel I'm heard?
Yes.
And do you take that in consideration when addressing them and continuing to build that relationship?
Yes.
And so in this case with the defendant, with Lindsay Clancy, did that change your approach with her at all?
It's why I sent the message that I did, trying to explain what addiction versus dependence and tolerance is. And I wanted to reassure her that we will try to have you take these less frequently, and we don't need to continue them moving forward.
So she advocated for herself, and you took that into consideration and created an alternative plan, or suggested an alternative plan?
Yes.
Did your care of her change at all when she told you she wasn't being heard?
I wouldn't say it changed.
You treated her as you would any other patient, right?
Correct.
Now, you continued to have messages with her throughout that day. Is that fair to say?
Yes.
And so at 10:02, you receive a message from her. It says, the insomnia started from the Zoloft, but then after the 2 weeks of daily Ativan and Benadryl use, that's when the insomnia was at its worst. I've tried so many different sleeping aids at this point, Trazodone, Ambien, Remeron, Seroquel, and they all seem to barely touch the sleep until I take Ativan with them. So tonight I will try 15 of Remeron with 50 of Seroquel. I fear that if I wake up in the middle of the night with intrusive thoughts again, I will feel like I need Ativan. Do you recall her sending that message at 10:02?
I do.
And that she sent another message, it's kind of cut off, but it's still within the 10 o'clock hour, where she adds, I also just feel concerningly numb right now. Like I have no emotion whatsoever. I feel like I'm going to die and I don't care. What do I do about this?
I do recall that message, yes.
And this is a message that she sent when she would have been or have seen Letitia Dukes already, right? If she had a 9 o'clock appointment?
Yes.
when she sent that message to you, did you respond back to her at 11:35?
I did.
And with the fact that she talked about being numb and having no emotions, feel like I'm going to die and don't care, what did you do?
I said, this sounds like depression and anhedonia symptoms. I would say if you're feeling unsafe.
Which is a dopamine issue. This whole time we keep talking about serotonin. Why are we not dealing with the dopamine? Hello? I've been talking about anhedonia and the inability to feel pleasure as it relates to like ADHD. They're only relating it to depression and focusing on serotonin. Not a single fucking medication for serotonin is working for a reason here, doctors and nurses. Because you're not dealing with a fucking serotonin issue. Your meds aren't working for a reason. You're not looking at the full picture. You're forgetting part of the equation and trying to stuff a round peg in a square hole. Can we take a look at the book Dopamine Nation, please? Maybe consult Dr. Anna Lemke. See what she has to say. She's already wrapped up in another trial right now, though. But that might help that doctor in the defense.
Safe, particularly as we head into the weekend. It is important for you to have information for psych emergency services available to you, and I provided a list of the 24-hour emergency service programs like mobile crisis intervention.
Okay. And when you say anhedonia, excuse me if I mispronounced that, what does that mean?
Anhedonia is a symptom of depression where people are unable to feel pleasure. They might describe it as feeling numb. They're unable to.
It's not just a symptom of fucking depression. This is so like, God, I hate this. You have a whole platform to educate the world about a lot of conditions right now and a lot of things, and you're so cherry-picked by the fucking prosecution that you're not elaborating any further. Anhedonia is not specific to depression, ma'am. Not at all. It's also related to addiction, dopamine, ADHD, so much more. But then that opens the prosecution to more questions and doubt, right? But we're not going to do that. I hope to God the cross-examination of this witness does.
To look forward to things.
And in her message where she says, I feel like I'm going to die and I don't care, did you take that as a suicidal thought or suicidal ideation?
No.
And so did you tell her to go to the ER right away?
No.
Okay. Did you have concerns that she needed to get a higher level of care at that moment when she sent that message?
My concern about that statement was that I wanted her to have access to resources if it escalated or if it worsened. So I made sure she had it.
Okay. And fair to say you also at the end of that message indicate, are you able to get rest or reach out to your support system so that you can be helpful, so they can be helpful to you right now, and that this is hugely important?
I did say that, yes.
And 11:41 a.m. she responds, yes, I have support. My parents are here to help. And again, this is 12:02. Does this sound like side effects to Remeron or Seroquel? I have never felt anything like this before. And then 11:57, she sends another message. Do you think over time these symptoms will go away over time? 12:04, another message from her. Is there any chance you could give me a call to discuss when you have a minute?
The mental numbness and like the feeling nothingness is, it really does seem like it's a side, like that trazodone. I've seen a lot of people just zombied right out on that shit. Same thing with Seroquel, just feeling nothing. Your meds are making it worse.
Minute at 12:10 p.m. And just to confirm, your recommendation for tonight is 15 Remeron, 50 Seroquel, and avoid Ativan even if I'm not sleeping. So you got those messages in succession, right?
I did.
And were you able to eventually respond to her with a phone call?
I responded to the message at 12 p.m. I wrote it down for her.
And again, in your response to her, did you reiterate that these are pretty common signs of depression, and that what she was expressing to you wasn't uncommon in women with postpartum depression?
Correct. I said it sounds more like depression than side effects. It's not uncommon for me to hear, I've never felt anything like this before, or I just don't feel like myself. All of this sounds like postpartum depression.
And did you further try to give her some encouraging words?
Mm-hmm. I shared a passage from a book called This Isn't What I Expected.
And is that book kind of centered around postpartum depression?
Yes.
And did you also tell her this is going to get better?
I said, even though they feel terrible, remember that they're symptoms of an illness that is very real and very treatable. This is going to get better.
And after that message on 12/12, did you in fact send her another message?
I did.
And fair to say that next message was to kind of address the concern about her question, what to take.
Yes.
And you confirmed to take 15 milligrams Remeron, 10 milligrams Prozac, and 50 milligrams Seroquel.
Yes.
And that taking Ativan every other day might help.
I said, I would say taking Ativan every other day might help you to see you are not addicted, as one cannot be addicted to something they don't take every day, but we can also decide to let me be concerned about whether you have a problem with the Ativan and simply take it nightly for now. And if I have concerns about your use of it, I will make them apparent to you. My primary concern at this time is that you sleep, and if that means taking the Ativan for middle of the night wake-ups, that is what it means. I'm confident we can safely and successfully get you off Ativan in the near future. And then I also go on to make recommendations about if she does have trouble in the middle of the night, certain sleep hygiene techniques that she could do, like getting out of bed, and doing something non-stimulating, and then go back down to try to sleep again when you feel drowsy.
So an alternative as to medication intervention.
Yeah.
And then at 1:40 p.m., she responds, "Thank you. I'll stick with that plan. I really hope it works, and to feel like myself soon." Right?
Yes.
And then at 2:35, you respond, "We will follow you closely. We have lots of alternatives. If this for some reason isn't the combination, we'll find one that gets you back to feeling like yourself."
I did say that, yes.
In all your treatment of women, the women that you've treated with postpartum depression, is this common that you have to kind of trial different plans in order to find the right one?
Yes.
All right, Ms. Buckhead, it's 11 o'clock. Why don't we take the morning recess at this time? All right?
Thank you.
So we'll take the break.
Court, all rise. Judge, if I can close your notebooks, this is on the chairs, please. This way.
All right. Counsel, anything we need to discuss before the break?
I think it is.
All right, so we'll be in recess for the morning recess at this time.
Court is back in session. You may be seated.
The difference in medical care between these providers is so vast.
All set for the jury?
Bring in the jurors when you're ready.
This court's now in session. Please be seated.
Your Honor, for the purpose of the record, we return back to the matter of Commonwealth versus Lindsay Clancy. All parties are present, including the 18 jurors.
All right. Three Buckingham, please.
Thank you. Nurse Jollotta, when we broke, we were talking about your interactions via my chart with Lindsay Clancy on December 2nd of 2022, right?
Yes.
And so the last one on December 2nd at 2:35 p.m. was from you to her. And then on December 3rd, do you recall that a My Chart message was sent on that day at 7:24 p.m.?
I do.
And you were able to review that message some point after it was sent?
I was.
And she reports to you basically that she didn't want to wait to let you know some things that were fresh in her mind. And it says, last night I didn't take Ativan. My dose had been the night before at 1 a.m., only slept about 4 hours at the beginning of the night, about 9:30 to 1:45. Then I dozed off for maybe another 45 minutes from 4:30 to 5. Today all day, I had horrible, intrusive thoughts and felt deeply depressed. I finally took a 0.5 of Ativan at 6 p.m. and now the thoughts are gone and I feel good. You recall receiving that message?
I do.
Okay. And fair to say there was no more communication between you and her until December 6th.
Correct. I believe December 3rd was a Saturday.
And you actually were out of the office on the 5th with sickness.
I was.
But you were aware that Lindsay Clancy did reach out to the office on December 5th.
Yes.
And that the nurse was able to respond to her to let her know that you were out sick, right?
Yes.
And Lindsay Clancy responds at 8:30 a.m. that day that she would just reschedule. Lindsay reaches out to the nurse and says that's fine, she'll reschedule, and that she in fact changed her appointment with Letitia Dukes to a virtual appointment for that day, for December 5th.
Yes.
So on the 6th, when you return, did you have a scheduled meeting with Lindsay Clancy?
Yes.
And on this particular meeting on December 6th of 2022, do you recall if that was an in-person or a virtual visit?
It was an office visit.
Okay.
In person.
And so just kind of looking at the note from that day, from December 6th, it says encounter date December 6th. It says filed on December 7th. In the under chief complaint history, do you have it in front of you?
Yes.
The second paragraph says patient has verbally consented to this video visit. Is that just something that sometimes pre-fills into the narrative?
Yes.
But your memory was that this was an in-person visit.
It was.
Was Lindsay Clancy there by herself or with somebody else?
She brought in her husband, Patrick.
Had you met him before?
I had not.
Had you talked to him before?
I had not.
As part of your treatment plan or your course of treatment with Lindsay Clancy, was it your practice to speak with collateral individuals?
Yes.
And in this instance, did you feel a need to speak to collateral individuals up to this point?
Not up to this point.
If you did, would you have requested that of her?
Yes.
And do you need her express permission to do that?
I do.
So on this particular day, she presented with her husband, Patrick, correct?
Correct.
And was there anything different about your approach to the meeting than your previous meetings with her?
No.
You still go through history, you go through how she's doing now, you do your mental status exam, you do your screenings, right?
Yes.
And so first, just let's talk quickly about the screenings. The Edinburgh screen, what was her score on this day when she came in? Do you remember?
21.
Okay. And the GAD-7, fair to say that screen was a 19.
Yes.
So would you say that it was pretty consistent with the last time that you saw her?
Objection.
What's your objection?
My objection is that that's not right.
He's now got a 21 Edinburgh scale. Prior testimony was not anywhere near 21. It's deteriorated.
Well, I'm gonna allow that question. On cross-examination, you can certainly explore the basis of what her opinion was. So I'm gonna allow that question. Go ahead, Como.
Well, let me ask you about that score of 21. It's 21 out of how much?
30.
So in what range is that?
Moderate severe.
Okay. And on your previous encounter with her on, or your actual telehealth on November 29th, you reported that the score was 17, and that's moderate.
Moderate. Yep.
And then on the GAD-7, on this particular day on December 6th, it was 19, right?
Yes.
And on the previous visit, it was 14.
Yes.
Okay. So as far as your observations of her on December 6th, did you notice anything different about her speech and language?
No.
How about her mood? What did you note her mood to be?
Anxious.
And the affect, fair to say, consistent with mood, meaning anxious, right?
Yes.
And thought process.
Thought process was linear and goal-directed.
And thought content, did she indicate to you whether she was experiencing any auditory or visual hallucinations?
No.
Any delusions?
No.
Any suicidal ideation, a plan, or intent?
No.
And as far as your observations of her during this interaction, this in-person visit, did you observe any signs of psychosis?
No.
Did you observe any signs of mania?
No.
Did you observe any signs of obsessive thoughts or compulsive behaviors?
No.
Now, when you met with Lindsay and Patrick on December 6th, did she or did they report why Patrick was there?
I don't recall if they indicated why he was there. I understood it to mean he was there to provide collateral and support for her.
Were you aware that he was coming to the appointment?
I don't recall if I was aware beforehand or not.
And you had engaged in a pretty significant my chart back and forth with her in the days preceding this this meeting on December 6th, right?
Yes.
Did she ever indicate to you Did she ever indicate to you in those messages that she wished to bring him along to one of the visits?
No.
Fair to say, when a person brings a collateral and is willing to have somebody speak, you're more than happy to get that information.
Absolutely.
This person, this collateral person, can they offer you a different perspective about the patient and what they're going through or what they're, how they're presenting?
Yes.
In this December 6th meeting, or the visit, did she report to you some changes in her sleep or significant concern for sleep?
I would have to review the note. What I remember is that the sleep really hadn't improved much beyond getting a few hours, waking up in the middle of the night, maybe piecing together more time.
And fair to say, there was some conversation to go back and talk about when symptoms started and try to get to kind of the root cause or what they believe the root cause of her symptoms were.
Yes.
And did Lindsay and Patrick report to you the connection with the Zoloft medication in September as a concern?
Yes.
And that at that they reported that, or she reported, that exact night I went from 25 to 50 milligrams. I didn't sleep for 48 hours and I wasn't tired.
Correct.
So that's in your note as a quote, meaning that's directly what she told you?
Yes.
Did you express to Lindsay Clancy on this particular meeting?
Okay, okay.
Did you express to Ms. Clancy thoughts that you had about her diagnosis based on your interactions over the last few weeks?
I did.
And what was that?
I discussed with her and her husband the possibility of potentially an underlying bipolar disorder. I based this on several factors, one of them being that she had such what we call an activating response to the Zoloft. It's unusual for somebody to describe taking Zoloft and then going 48 hours without sleep and not being tired. So that raised my clinical suspicion a bit. And she had been, I would say,
You know what raises my suspicion more to her being drugged? Is the fact that it takes a long time for these medications to kind of build up in your system. It's not like you take it and it's just like, oh my God, unaliving thoughts. Like you really have to like get into it. And they get like increasing. This is not typical behavior of somebody given psych meds. I mean, these are a lot of meds in a short time. A lot of them are low dose. The interactions don't make sense, but if she was being drugged, it would. That would make sense. And it wouldn't show up on a tox screen because there was no blood work even done by any of these fucking doctors. To even see, like, if it was, like, you know what I mean? It'd be so easy to slip things into her, and then if she goes to a doctor because she's feeling fucking nuts, and then they give her more, and it's counteracting what she's being drugged with, I mean, like, that would definitely cause some issues.
having difficulty tolerating other antidepressant medications that we had been trying to have her take since then. And so again, I'm wondering if it's because potentially there might be an underlying, what we call mood disorder, bipolar disorder.
And as far as the information that you had about her past psychiatric history, were there any indicators to you about manic episodes?
No. So I do recall in reviewing Julie's note prior to meeting with Lindsay, she filled out what we call a mood disorder questionnaire. It's like a screener somebody can do to assess history of mania and bipolar disorder. Lindsay it was a negative screen. So there's 3 questions. One question has 13 different symptoms. You have to score 7 out of 13 on question 1, but also in question 2, it asks about, are the symptoms happening at the same period of time? And then it asks about any functional impairment from the symptoms. So I recall the 3 symptoms she did endorse were not sleeping for that period of time with the Zoloft and not feeling tired, having racing thoughts, and trouble concentrating. None of the other symptoms did she endorse. They did occur at the same period of time. And I don't want to be inaccurate, so I can't remember what she said for functional impairment, but I believe it was minor impairment.
Okay, and so the fact that those were reported, but ultimately the full screen revealed negative for potential mania.
I did also consider, though, that the MDQ is less specific when it comes to bipolar 2 or bipolar not otherwise specified. There's bipolar 1 and bipolar 2. Both have mania symptoms as part of the diagnosis. Bipolar 1 is usually more severe in that it's typically, you know, a patient might be hospitalized or it causes greater functional impairment. Bipolar 2, it's a shorter duration and typically less functional impairment.
And as far as determining diagnostically whether somebody might be presenting with bipolar disorder, is there a particular tool you use in your trade to try to assess that?
Typically something like the MDQ, and then you'll do more of an interview asking the patient about symptoms specifically and if they can ever recall a time where this may have happened in the past, because sometimes patients can't always remember when they're manic. So I was glad to actually have Patrick in the visit because he could sort of help us look at Lindsay's history more longitudinally, or at least since the time he knew her.
Okay. And as far as, so those tools that you're talking about, the MDQ and kind of screening tools that you use in practice, is there another tool that you use to assess whether a person meets particular criteria to be diagnosed with bipolar 1 or bipolar 2?
There are others, not ones that I've used.
So are you familiar with the DSM-5?
Oh, yes, yes.
Okay, so while that's not the end-all be-all, it is a guide that tells you specific criteria, how to determine if episodes are manic or depressive, right, when it comes to bipolar.
Yes.
The difference between mania and hypomania.
Yes.
And so while you noted that there were some concerns reported, did what was reported to you rise to the level of diagnostic criteria for bipolar disorder?
Not at that time.
Okay. And when you explained this to them, your thoughts about her reactions to the medication and these reported prior symptoms, did Patrick and Lindsay seem receptive to your diagnosis?
I recall Patrick saying my wife is not bipolar. Lindsay looked at me. She did not say anything.
Okay. And was this the first time in this meeting on December 6th where you broached that issue or mentioned that?
Yes.
Did the conversation continue about symptoms and managing symptoms after that?
Yes.
Were you able to get any more specific information from Patrick during that meeting? Not what he said particularly, but did you get additional specific information that kind of helped you assess whether you would change your diagnosis at that point?
No.
And were there still concerns in that particular meeting that the focus was trouble sleeping and the potential for addiction?
Yes.
As far as recommendations, did you talk about what's called tapering medication?
Yes.
And what were your recommendations regarding tapering?
So we talked about her concerns about the benzos. And we decided to come up with a plan to taper off of them.
And the last that had been reported to you via the MyChart messages was that she tried not taking it at all, ended up having horrible thoughts and felt deeply depressed, then took it and felt better. Right? So was it realistic to recommend completely stopping?
No.
So what is a taper? Like, why do you recommend tapers?
I recommend tapers to slowly get somebody off of something. And tapers can be useful because we might have somebody at a dose and they might say, oh, I'm too anxious to stop this, or I'm not ready to step down to another level, and we can kind of keep them on it longer. But at this point, since I had met her on November 29th and throughout the MyChart messages, there was multiple concerns voiced about benzodiazepines, and again in this visit. So
Okay, and remember, in this visit, this is where Patrick shows up. He's never in, like, did you hear the prosecution? Like, you literally just asked, has he ever been in the visit before? Is this typical? No, 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 no. But now here is this focus on these benzos again. Why are you telling your wife that she's addicted after 2.5 fucking weeks? I was married to a man like you.
I even did what's called a CWA assessment, which is something we use to determine if somebody's having actual withdrawal from benzodiazepines or alcohol. Again, I really wanted to show her I was assessing this and taking this seriously.
When you say CWA assessment, is that an acronym for something?
Yes, so it's
What are the letters, just for the record?
CIW, CIWA. CIWA.
Okay. And did you, when you do that assessment, does it give you some sort of score?
It does.
Ask the questions. And what was her score when you did that CIWA assessment?
1.
And what does that mean?
Minimal to no withdrawal. The only symptom she reported was anxiety. Her blood pressure was normal. Her pulse was normal. She had no nausea, no vomiting, no tremor, no tactile disturbances. People in withdrawal from benzos or alcohol will sometimes feel like there's bugs crawling or pins and needles. Auditory disturbances, so hearing things, seeing things. No sweats, no headache. She was oriented.
Okay. So with that, and knowing that she wasn't in withdrawals for Ativan, did you still recommend the taper and an alternative?
I did.
What was that?
I recommended Valium. The reason I recommended this is she had discussed rebound anxiety with me at our very first visit, feeling that rebound anxiety above her baseline once the benzo wears off. Valium has an extremely long half-life. It can, as in like 100 hours. It has a longer clinical duration of action. So I wanted to offset the chance that she would experience rebound anxiety. And it's often used when we're tapering somebody on shorter acting benzos. It's common practice to switch to longer acting benzos to do this.
And did you also have conversations about the other medications that had been at issue, the mirtazapine and the Seroquel?
Yes.
What did the defendant, what did Lindsay Clancy express to you as far as Seroquel? Did she want to continue with that?
No.
Did she explain why?
So she felt like when she took Remeron and Seroquel together, she felt weighed down and exhausted, but her mind was still awake and alert, and she just didn't seem to think there was a benefit to being on it.
And so did she express to you a desire to want to go back to trialing Prozac?
Both Lindsay and her husband expressed that that was their preference.
And was that something that you agreed with?
Right there. Both Lindsay and her husband. Why does her husband have any fucking input as to the medications that she is taking? That is none of your fucking business. That shouldn't be any... Like, this is the husband. This is all the husband. I'm sorry. Not sorry. Not at all.
I did. I had shared with them that I had concerns could be bipolar. It's in my differential diagnosis, which is just all the typical diagnoses we might be considering. And that typically SSRIs are contraindicated, but she did have that history of being able to tolerate Prozac at 20 milligrams and do okay with no.
From all of the behaviors and the anhedonia that you're like explaining, like I think all of these medications are contraindicated. Like like her body is saying no for a reason.
Mania. So I thought that's what they were wanting to do, so we could do it. We could try it.
When you say contraindication,
Okay, sorry.
what does that mean?
It means typically not something you would want to do if you were sure somebody had bipolar disorder, because if you put somebody on just an SSRI or like Prozac, like Zoloft, it can create a scenario where people are flipping back and forth between manic symptoms and depressed symptoms, or they're called rapid cycling. It's not that antidepressants or SSRIs are never prescribed in bipolar disorder, but you often would want to have a mood stabilizer on board at the same time.
I feel like he was trying to make her appear
And
that
so,
way.
Despite your suspicions, you listened to the patient and went along with her request.
Yes.
So at the conclusion of that meeting, did you indicate that she could discontinue the Seroquel at that point?
Yes.
With the plan that she was going to restart Prozac?
Yes. Which I had been recommending the Prozac. Earlier, I believe even on November 30th, I had recommended it.
And with that previous recommendation, it was in addition to the Seroquel.
And the Remeron, yes.
So after this meeting, on December 6th, did you have additional communications with Lindsay Clancy via the MyChart messaging on December 7th?
Yes.
And fair to say that those communications started as early as 9:48 a.m. when she sent the first message, right?
Let me just make sure. Oh, yes. Yes.
So on December 7th at 9:48 a.m., she sends a message saying, "Hi, Rebecca, last night did not go well at all. I took the Valium and melatonin and only slept from 9 to 1. Then around 2, I got desperate and took 25 milligrams of Benadryl and only slept about 1 more hour. What can I do? I really need help." So that was the message that you came into on December 7th, right?
Yes.
And did you respond to her in the messaging app?
I did.
And what was the response?
I'm trying to find the sequence.
At 10:19 a.m.
Then it gets cut off. Okay. So I discussed, I mentioned, so your husband made a good point yesterday. Despite taking the Ativan in the evening, you were still only able to get a 5-hour stretch of sleep, which, yes, is improvement, but does sort of dispel the notion that benzodiazepines are the only thing that are helping you sleep right now, as you are still getting less than the target of 6 to 8 hours with Ativan, and the Valium did not help for sleep much at all. My next step in this case is to try a higher dose of Seroquel on its own. Are you feeling any subsequent loss of energy, exhaustion, fatigue with lack of sleep?
Why would it be the next step to increase from 75 of Seroquel to 100?
So she had been taking 50, so I was suggesting 75 to 100 would be my next step, because again, bipolar is still on my differentials, and now I have the data that she only slept 2 hours. So I asked her the follow-up question, are you feeling tired? Or, are you feeling exhausted? Any subsequent loss of energy? It's still in the back of my mind that this could be bipolar.
So as far as the Seroquel goes at that point, creeping up the dosage, do you get now from the using it to treat insomnia to using it to treat something else like bipolar?
Correct.
And so that piece of it about feeling subsequent loss of energy and exhaustion, fatigue, why ask that?
Patients can have insomnia because they're anxious or because they're depressed, but typically they're exhausted or they're tired the next day, and it really does affect them. If a patient has an underlying bipolar, they could go on 2 hours of sleep and not feel tired at all, and that's unusual.
And so that is one of the signs, potentially, of a manic episode?
Potentially, yes.
So on December 7th at 10:33, she responds, no, the weird thing is I don't feel tired at all. And she says, so just Seroquel tonight, ? I feel like I'm going to panic without a benzo with it. And then again at 11:44, another message, would I be able to do the Valium with Seroquel? Is that a safe option? So again, in this exchange with her in my chart, she's asking you questions to clarify what you've said and also alternatives to address the issue, right?
Right.
And as far as her questions go, and then her response about not feeling tired, how did you respond in the message?
So she kind of sent those in succession. So I don't feel tired, would I be able to do the Valium with the Seroquel? So I respond by, if you're not sleeping well with the Valium alone, there's no need to continue it, and I will prescribe a short taper to get you off benzos altogether. Because you are not tired at all and had a significant reaction to Zoloft at 50 milligrams, I'm concerned this is an underlying mood and bipolar disorder. I know you and your husband did not necessarily agree with that, but I feel that I'm going to send along this information to review. So I sent her a list of symptoms of bipolar, risk factors, so that she could have it to refer to.
And again, at this point, the only symptom she was reporting of mania was this not being able to sleep and not feeling tired, right?
And yes, and the racing thoughts and the trouble concentrating.
Okay, is that things that she had reported to you in your visit on the 6th?
No.
Okay, in these messages that she was sending to you in her, on December 7th, she didn't talk about racing thoughts, did she?
No.
Okay, she just talked about the sleep?
Mm-hmm.
Okay. But based on a review of her history, she had at one point indicated that she was feeling those in relation to a symptom she was describing. Is that
correct?
So at this point, what do you recommend her to do?
I explained the importance of knowing if this is bipolar is significant, because SSRIs like Zoloft and even Prozac would be contraindicated. My recommendation is to do 100 milligrams of Seroquel tonight, 200 milligrams of Seroquel tomorrow night, 300 milligrams on 12/9, 400 on 12/10, and we will hold there. I actually say hold the Prozac, as I'm concerned this is a hypomanic mixed manic state.
And what about the Remeron at that point? Where did this fall into the mix, if it fell in at all?
I had recommended a very short taper on December 6th. I think I advised her to take half of a 7.5 milligram tablet for 3 nights, but in her message to me on December 7th, she had not taken it that night. So I had assumed she had just stopped that entirely.
Okay. Now, after you sent that message at 12:32, did she respond at 2:53, indicating that she would stick with that plan and that she said she needed a refill on the Seroquel because she only had 30 25 milligram tablets?
There were actually, she did say that. There were actually a few earlier messages as well that day. I provided an alternative. One as an option, it quickly came into my mind, oh, we're thinking about Prozac we could add Zyprexa on board because there's actually a combination pill of Prozac, Zyprexa. The brand name is Symbyax, and it's for bipolar. And I said, for our purposes, we can prescribe them separately and take them both for the same effect. And I asked her to let me know which one she would prefer. And she responded, I think I would like to do the Seroquel with the Valium taper.
Okay, so that suggested alternative actually was on at 12:37.
Correct.
And then at 1 o'clock,
And Mary, I speak from my own personal experience as to why I say this, because like my ex-husband was so gung-ho on me taking meds. I had to be bipolar. And I'm like, dude, I've always argued this. I've always said I'm ADHD. I feel that there's some trauma. And then he just further traumatized me, right? But it was like, it was his focus. And when he went to the clinic and my doctor took me off everything because of my crash, like I was walking, like I was passing the fuck out on all that shit. It was like, I feel that she had a wake-up call to him and he started drugging her to make her the crazy one, is really what I feel, because it was attempted to have done to me. But, you know, in the process of him being such a great evidence keeper, you know, he had it all on his computer. I went back and looked at every marriage, and he did this to everybody, and everyone was institutionalized. And I'm like, this is a pattern for you. It's not me, it's you. He's establishing this pattern with himself. But this is the fallout. This is really what I feel that this case is.
she elects
really
that she'd
hit
like to do
home
the Seroquel with the
hearing this
Valium
shit.
and asks for you to call in the Valium and the Seroquel.
Yes.
So that's on December 7th, right?
Yes.
On December 8th,
And in the meantime, he's wanting my fucking Xanax for his
at
PTSD.
6:35 a.m.,
Which it shouldn't even
she
be
sends
used
you a
for.
message saying, did well last night, need Valium,
And I had generalized
feeling
anxiety
panicky,
disorder.
don't
Have
know if ready to
been
taper as
diagnosed with
quickly as
that for
planned.
years.
Yes.
Kind of paraphrasing, but
Yeah, she exclaimed, I actually did really well last night with the Valium and Seroquel. I mostly slept from 9 to 5 with a few wake-ups, but was able to go back to
What I hear is a woman with medical knowledge like me being manipulated at a very, very vulnerable time in her life. Kind of like what TikTok did to me. I see the parallels. I can see what happened here. She's an intelligent, she's a fucking laborer. She's a Jen Hamilton. Imagine this happening to Jen Hamilton. After what her... Okay, let's actually talk about that. If you look at the fucking mind-altering shit that Jen Hamilton just went through with her husband, living a double life while she's this huge public figure, just wrote a book as an LDR nurse. That's what, like, this woman was a labor, like, she was a Jen. Had kids, and I get, like, this motherfucker got remarried in this short period of time. You were fucking around to begin with. You didn't just meet, fall in love, and kumbaya. It's exactly what happened here. I'm telling you. I'm fucking telling you.
sleep. She was concerned that she felt like she needed to take the Valium around 5 p.m. because she was feeling panicky. I feel really dependent on it. Can I taper any slower?
And what was your response to her request for a slower taper?
I said, I'm hesitant to taper any slower. Remember, Valium has a really long half-life, 100 hours, so you will have some on board in your system throughout the weekend.
And why were you hesitant to taper any slower?
I felt like she was anxious about being dependent on it, and so I was trying to facilitate the process of tapering her off, and I was clinically thinking we could cover her symptoms of anxiety as we titrated the Seroquel, because Seroquel actually has several clinical trials that show it has really good efficacy for anxiety.
And this conversation about the request to taper, that actually goes into December 9th of 2022, correct?
Yes.
And in her response to your indicating you were hesitant to taper, she indicates that she took the 5 milligrams of Valium and that she didn't have any left, and that she was afraid that she was going to take Ativan.
Correct.
And had you recommended to take Ativan as an alternative or in lieu of Valium?
No.
Were there any more communications on that day, December 9th of 2022?
Yes.
What were they?
Later that afternoon, Lindsay and her husband called.
Okay. And so did you, fair to say they called the clinic, leave a message, and then you called them back?
Yes.
And when you called them back, what was the nature of that conversation? What did you guys talk about?
Her symptoms, we discussed that the plan was to taper the Valium over the weekend, but they both agreed that Lindsay's symptoms were too acute. She's sleeping better, but still waking up with panic symptoms and intrusive thoughts, feels numb, has thoughts of SI, but no plan and no intent. I encouraged her to engage with women and infants in Rhode Island to complete an intake for a partial hospitalization program. But she was able to contract for safety over the phone with her, with the 3 of us on the phone, that she didn't have a plan, no intent, that she would reach out if needed. I did agree to continue the Valium until our next appointment, which was scheduled for 12/13. I prescribed it as 5 milligrams, but I advised her she could take a half tablet twice a day, so 2.5 milligrams twice a day.
Walk me through that. She had she had indicated to you that she wanted to slow the taper.
Yes.
And then you said no, that wasn't a good idea.
Right.
And then on the 9th, they call you and say that she doesn't want to taper. She wants to stay where she is, right?
I think it was that same day. The messages were earlier in the day, and then later in the afternoon, around, it's noted at 16:10, so 4:10 p.m., that she and her husband then called, advocating to stay on.
And in advocating to stay on the Valium, that she reported she's still waking up with panic symptoms and having intrusive thoughts, feeling numb, right?
Yes.
So in addition to agreeing to continue the Valium, did you make a recommendation about the Seroquel?
Continue the titration.
So when you say titration, what does that mean?
So I had recommended 100 on day 1, 200 day 2, 300 day 3, 400 day 4. This is the manufacturer recommended titration schedule to treat manic symptoms. Because again, I had shared with her, I think this is a mixed manic, hypomanic state. So that's what I was targeting.
Okay, and so as far as Seroquel goes, there's some guidance you get about Seroquel that's put out by the FDA, right?
Correct.
And it talks about dosage and administration for every drug, essentially, right?
Yes.
And as far as Seroquel goes, there is different recommended dosages or ranges for different mental illnesses that you're treating.
Correct.
So in this instance where bipolar is in your differential diagnosis and you're recommending titrate up to 400, is that consistent with the thought that you believe she had bipolar diagnosis?
Right. So I was thinking it was a mixed manic state or possible hypomanic state. A mixed manic state is when patient has symptoms of mania, like poor sleep, no loss of energy, but they also can feel depressed, numb, suicidal. It's sort of like it's a mixed state. It's a mixture of symptoms. A mixed state presentation is clinically acute. It's unstable, so I really wanted to get the manic symptoms under control. I really wanted to get her to sleep.
And so going up slowly to 400 milligrams, what's the recommended dosage range for somebody with bipolar disorder of Seroquel?
For somebody, a manic presentation, you can titrate over days rather than weeks. You can actually go up to 800 milligrams.
And so even though you had previously indicated to them in your December 6th meeting that you were agreeable to discontinuing the Seroquel. Based on our presentation in the days following, did you change your recommendation?
Correct.
And with the increased Seroquel that you had requested as of December 9th, she was reporting sleeping better, right?
Correct.
And that had been something that had been a recurring concern in your interactions with her, sleep?
Yes, my understanding was that she had been sleeping poorly since October.
And was there, when you say you were recommending partial hospitalization during that phone call, did you give a particular place in which you would recommend her to try to seek treatment?
Women and infants.
And that's in Rhode Island?
Rhode Island.
And are you familiar with whether they have particular perinatal or postpartum programs there?
They specialize.
After that call with the Clancys on December 9th, when was the next time you had contact with Lindsay?
December 9th was a Friday, so I believe it was Monday, December 12th.
Now, people are able to send my chart messages all hours of the day, every day of the week, right?
Correct.
But in this instance, you did not receive any messages over the weekend?
No.
So the next my chart exchange was actually on December 12th of 2022, correct?
Correct.
Now, on December 12th, do you recall who initiated the contact via my chart?
Lindsay?
And at 1:59 p.m., she sent a message to you saying, I've been noticing on my Apple Watch that my heart rate has been fluctuating more than usual. It has been going from 56 to 136 within a matter of minutes. I'm wondering if this is a side effect of the Seroquel and if there's anything I should do about it. Thanks, Lindsay. Do you remember getting that message?
I do.
And again, at that point, as of December 12th, you had recommended the titration plan going up to 400, right?
Yes.
So by that Monday, where should she have been if she was following your instructions?
400 milligrams.
And did she report to you whether she took 400 milligrams of Seroquel?
She reported she was taking 200 milligrams.
Did she say why?
No.
But your recommendation was that she should have been up to 400 at that point.
At that point, yes.
As far as the concerns about the fluctuating heart rate, were you able to address that with her in a response?
Yes. I explained that medications like Seroquel can cause something called orthostatic hypotension, which is basically when you get up from sitting or standing, your blood pressure doesn't compensate in time, so it goes low and people can feel dizzy. I explained that the mechanism for that is alpha adrenergic blockade, so the alpha receptors that help us with like adrenaline. They're also part of the picture here with Seroquel. It's often accompanied by orthostatic tachycardia, meaning getting up from sitting to standing, your heart rate can fluctuate. I said both can be common in the first days of medication exposure or when the dose is being increased. It's generally benign, meaning non-harmful, and self-limiting, meaning it goes away on its own over time. I also advise it sometimes necessitates slowing a dose titration or dividing a dose into like 2 or 3 smaller doses.
Okay. And so with this response and trying to address these concerns, you're aware that she had spoken to the nurse that morning?
Correct.
And that she had expressed to the nurse a desire to get off the medications altogether?
Correct.
And what was your response to that concern that she had in the call to the nurse? What did you tell her?
I said, as long as you are aware of the risks, I don't think you've been on Seroquel long enough for it to have a positive benefit on your mood or anxiety. But if you've noticed benefit, if you have noticed benefit, the risk would be worsening of mood and anxiety upon stopping the medication. We also discussed tapering off the Valium, which I'm fine with, if you would like to like me to send along the taper schedule. Being off medication might help you see where you are at baseline, but I do think you are experiencing significant and severe symptoms of postpartum depression that needs to be treated. I acknowledge that medication alone is not always the best option for someone, but often it's part of the puzzle. Other treatments include counseling, support from others, exercise, healthy diet, yoga, and relaxation techniques. I know this has been brought to your attention several times, but I strongly, strongly recommend a partial hospitalization program so that you can get started on utilizing these treatment methods for relief.
And you were aware at this point, as of December 12th, that she had met with Letitia Dukes at least once, right?
At least once, yes.
She had been given referrals for CBT or cognitive behavioral therapy programs out in the community, in her community, right?
Yes.
There have been other recommendations for her to obtain a partial hospitalization program at that point.
Yes.
Now, anything about these exchanges that made you concerned that you had to kind of raise the level, meaning call her in for another meeting or make any sort of recommendations for inpatient hospitalization?
Not at this junction.
And why is that?
I wasn't, she wasn't reporting any acute safety concerns in these messages at this point.
It's just physical side effects.
Physical side effects, yes.
So the messages continued on December 12th, correct?
Correct.
So at 2:44, Lindsay messages you saying, "Thank you, Rebecca. It does seem to be orthostatic, and I'm glad to hear that it's benign and known side effect." And then she tells you a little bit more about the prior nights, right? So she says, "So the last 3 nights I've taken 2.5 milligrams of Valium and 200 of Seroquel. I have to say that I do like the way it makes me sleep very deeply and soundly for around 7 to 8 hours, but I don't like the way I feel in the morning and most of the day. Incredibly depressed and unmotivated to do anything at all. What would you recommend for tonight?" Is that the next message after you explained to her the side effects?
Yes.
Okay. So, and for 10 p.m., you respond to her, don't you?
Yes.
And what did you recommend to address those concerns about incredibly depressed and unmotivated?
So at this juncture, I recommend...
You know, Remy, you're right. And I don't think it's just the doctors. Like, the doctor had I can see where the doctor's mind is, right? They had a treatment plan in place. The problem is there's other doctors like the other one who was seeing her but not prescribing some of these meds, but other ones, right? They're not collaborating. And then you have a husband who is insisting she's getting it. Ooh, those are hot still. Addicted to Ativan after 2.5 weeks. So yeah, she's rapid cycling, but it's what's going on in the house behind closed doors. You know what I mean? He's suddenly at this December 5th visit, never been there before, and he's insisting that she needs to get off Ativan and go on something else. But Ativan's what's working because it's calming her fucking nerves to deal with him. Right? Nobody looked within the household to see if anything else was going on. We weren't looking anywhere else with the anhedonia. We're making it exclusive to depression. There you go. And it's not. It's absolutely not. It is a dopamine issue as well. And there are so many other issues that could cause these symptoms. And these doctors are so quick to fucking label people with a goddamn mental illness. And like, this is what they're trained to do now. That's your first answer. Give them some drugs. I think him and that new doctor wife were having an affair for a while. I think he was drugging her, and that these medications that these doctors were giving her were interacting. That's where all this weird shit's coming from that these doctors can't explain. Of course, if you're taking shit that this is not a typical reaction to these meds, right? What's going on here? It should have been like, and I am sure if this tragic event wouldn't have happened, we would have gotten there, right? There would have been a doctor like mine out there that went, this shit's just not adding up. Like, let's start looking in the environment, because when things don't start adding up, we start looking environmental, and that's what my doctor did. Like, okay, this is PTSD. This is not bipolar. This is not. You've got a lifetime of trauma. You've not been diagnosed properly. You've been given drugs. Let's start clean. This is a problem. Your husband's a problem. And he was. She wasn't lying. That's why he probably didn't like her. She didn't go along with his narrative and, all that other good shit. He couldn't win her over. And I see this motherfucker. Like, I don't want my husband at my psych visits. Especially dictating what I'm taking and doing. And I'm glad that my psych doctor at the hospital that I, jumped out of a vehicle in Memphis to get away from my ex at, recognized my ex's behavior, no matter what his fucking rank was in the military. That doctor didn't give a shit. Thank God.
Recommended at least continuing the 200 of Seroquel because at least now she's sleeping. So I felt like although I had recommended getting up to 400, we had gotten...
Okay, well, this practice where she started going was seeing her in person and telehealth. This other doctor who doesn't know her ass from a hole in the ground, all telehealth. And she absolutely should be looked at for malpractice and negligence and wrongful death. Absolutely.
Sufficient, activation symptoms down. She was sleeping. And the 2.5 of Valium. I think I advise that we need to give time for Seroquel to work for your mood. Let's continue to accumulate good nights of sleep, as this can only be a good thing in terms of recovering and feeling better moving forward. I would say take them tonight, and we will discuss further at our visit tomorrow.
And you had a visit scheduled for December 13th, correct?
Correct.
The message continues on that day where at 7:17 p.m. where she says, okay, thank you. I need to make our visit virtual tomorrow. I will not be able to make it to the office. Can you please change it to that? Is that right?
Yes.
So after having met in person with her on December 6th, having had subsequent communications with her all through the date of December 7th and kind of, again, changing a little bit about the medication plan and having further communication with her on December 9th and now December 12th, the plan was for her to, again, come in person on the 13th, correct?
That was my recommendation, yes.
Why did you recommend in person at that point?
This was somebody who was communicating with me every day, and I did feel that she had significant symptoms of depression, some mixed symptoms with mania, anxiety. I felt that her symptoms were severe and significant enough that I wanted to touch base with her weekly, and I wanted to see her in person. But again, I was okay with her doing virtual because I'd rather see her and lay eyes on her and try to treat her than not see her at all, if that would have made her just cancel the visit outright.
Because generally you do the same thing whether you're in person or virtual, right? As far as getting the history, going through symptoms, asking how they're feeling, doing the mental status exam, right?
Mm-hmm.
Physical assessment, you can't see self-harm marks. You can hide things. You can make up. No. With a mental health, and if you're lying to your practitioner, like you're trusting a lot of what a new patient to you. You don't know this patient. You do not know this person. You are not established with them. You don't have a history before the pregnancy. You're going off of only what they're telling you in that moment. Psychopaths are really great at fucking like winning people over and conning them too, you know? Sociopathic people, they're real great at that. Professionals. Have you done a mock trial before you came to court, prosecutor? You are setting up this defense for a perfect execution of your argument.
So you meet with her on December 13th at 10:30, correct?
Correct.
And now this is a virtual at her request.
Yes.
And do you revisit with her kind of the recent events and the timeline of the changes that you've gone through the MyChart messaging?
Yes, I structured my note as like a recent treatment timeline. So I put, 12/6, what had happened, 12/9, what had happened, and then I write update today, 12/13. That's sort of for me to like remember the treatment history that I've had with her so far.
Okay, because while the MyChart messages are available to you, they might be in a different place, right? So they're not all contained within your same note.
Right. So I made note of, again, our visit on 12/6. I made note that she and her husband had called me on 12/9, and then I made note on the 13th. So I wasn't documenting all the MyChart messages, but just sort of my visit history.
Lisa, both. She's admitted to doing it, which is a problem. You should never admit to your crime. But I don't think it is the way that it's being portrayed. I think the husband was cheating. He's remarried to a doctor who I guess I haven't followed the whole case either. I got interested when the healthcare angle opened up. So I have a different interest than most people. The failure of this one doctor that's already testified is just insane to me. Like how she still has, how she graduated fucking med school is beyond me. Like the failure in healthcare of Lindsay and what led to this is my problem. This was wholeheartedly preventable and the girl was begging for help. I believe she was married to an extreme, manipulative, disgusting, dark, narcissistic human also. And I believe that they're married now, him and this doctor lady, not one that treated her, but knew her, because they're complicit and can't testify against one another. I think this was premeditated, but never expected to get this far. I think they wanted to lock her up and commit her. I don't think they thought she was going to harm the children and jump out a window. I think that's where the miscalculation was. That's my feeling, my personal opinion on the matter. That's what I see has happened. And this is probably going to be a Netflix documentary and a plot for a movie real soon. I say this because I was married to a man who asked very much the same questions, who was trying to do all the very same psych things. Like, he reminds me of my ex. And the eyes. Like, that's why it's like, this strikes all of our T's spidey senses. All of them.
With her and phone calls.
And it pisses me off.
And so when you saw her in this virtual visit on December 13th, was she reporting improvement in her sleep?
Yes.
And how was she sleeping?
Yeah, it's going to be interesting to go back to that. I keep hearing about this body temp at 82 degrees and a heartbeat. What is that Celsius? Hold on. Hey Siri, what temperature is 82 degrees Fahrenheit in Celsius?
Do you want me to use ChatGPT to answer that?
Sure, use ChatGPT.
Fahrenheit is about 27.8 degrees Celsius. That was from ChatGPT. Check important info for mistakes.
What temperature do we cool the body to in hypothermic protocol?
In therapeutic hypothermia, also called targeted temperature management, the body is typically cooled to about 32 to 36 degrees Celsius, 89.6 to 96.8 degrees Fahrenheit. That was from ChatGPT.
Whose body temp was that? Yeah, I'm gonna say, Nikki, at that point we're beyond hypothermia protocol. We're turning the hugger on, right? Lindsay's temp? Well, this did happen in January, right? And they're in Massachusetts. I could see that happening. I've worked a lot of patients pulled out of negative 40-degree temps. What was the temp there? Anybody know what the weather was that night? There was snow, so that is possible. But I'm going to have to hear that testimony. I'm going to go back and listen to it all. I'm not going to try to keep pace with the trial. I'm focusing on the healthcare angle, and I am going to go back and do my research. So what we're doing is RT's research together. If there's things you guys want to watch, I have put the link in Discord to keep up with the Associated Press. You can watch them live stream, and I'll learn new stuff in the case from you guys. But I'm really focused on this healthcare angle. This is a failure to recognize. This is a failure in education, a band-aid of fucking pharmaceutical industry. This is like a plethora of healthcare issues that I have talked about for years. Yeah, I heard about that, and I don't know if I want to watch all that. I'm going to stick to the healthcare, try to get summaries from AI, and keep my emotional distance, because what I went through with Rebecca Park, I don't want to do that again. I do not want to hear and read all those things again. I don't. I know they happened. I know what happened. I work in the industry. I'm so good. I don't have morbid curiosity like that. Oh my gosh, Tanya. I know how shit like this rocks a community. We had a mass pew-pewing in El Paso, and I worked the victims. I get that.
During that time period?
7 to 9 hours.
Okay, and that was holding at 200 on the Seroquel?
Correct.
And was she taking anything else daily?
Valium, 2.5, just once daily at night.
Okay. And while she reported sleeping better, she still had significant symptoms of depression, right?
Correct.
And what were the symptoms she articulated?
Hopelessness and, again, anhedonia, that feeling no pleasure, feeling numb.
Okay. And she also kind of complained of that racing heartbeat, and that's tachycardia, right?
Yep, the orthostatic tachycardia. So I recommended holding a bit longer at 200 milligrams. At this juncture, she had been on 200 milligrams for 4 nights. I wanted to continue it for a full 7 nights. And then we were still discussing whether to taper benzos, and our plan was to kind of slowly phase them out at that point. So we were going to decrease from 2.5 milligrams daily to 2.
At any point in time, did any of you discuss a safety plan with this new mother who was scared? Like in respiratory, especially when it comes to your children in school, we have like an asthma action plan, a red zone, a yellow zone, and a green zone. This is what you do in each zone with your meds. This is a bad thing. Did you have anything like that in place other than like resources from the internet that we can get from TikTok? No. Nobody consulted, and that's another point that I made to TikTok, because fuck, if none of these medical professionals who are real mandated reporters in contact with the patient, if this case would have been noted, like if she would have been a TikToker doing this, man, we would have had this wrapped up for him, right? This is insane. This is a failure in healthcare of the system as a whole, and it just exposes how broken it is. This is what our veterans have been dealing with for years, and now the rest of the people are dealing with it. And that's pretty much what these medical professionals are all telling you. Now, these nurse practitioners, these are the ones who have done the most for this woman. The fucking doctors have been worthless. Couldn't tell you shit. Big surprise.
2 milligrams for 7 days, and then we were going to reassess at our next visit in a week. I also provided psychoeducation about behavioral activation, CBT techniques to utilize for depression. I also recommended postpartum.net for support groups, and I reiterated that she consider a partial hospitalization.
And again, during this telehealth visit, you have these conversations with her, but you also do your mental status exam. You make observations of her, right?
Yes.
Did you observe any signs of mania?
No.
Did you observe any signs of psychosis?
No.
Did she articulate to you any suicidal ideation?
She had endorsed that she had had thoughts of it on the Edinburgh over the previous weeks, that she sometimes had thoughts of harming herself, but not at that visit.
Okay. And would that have been something you'd follow up on? Would that statement from the Edinburgh? Or
Objection. Would that be something you'd follow up on?
No, I'll allow that.
So just to clarify, so again, the Edinburgh,
After coming from the witness, Judge, I'm sorry.
Objection overruled. Next question.
the Edinburgh is over the previous 7 days. So she had that thought sometimes when I asked her, are you currently having SI? It was no during the visit.
okay. And it just was the response sometimes.
Yes.
And so, did you ask further in your interaction with her on that day, on the 13th, about whether she was experiencing suicidal ideation?
So I really feel that the husband, like I said, was trying to make her appear crazy to get her locked up. What should have happened is that she doesn't get to go home until the feelings that she is complaining about being overwhelming are under control and stable. But they keep discharging her too quickly. Oh, as soon as she's clear for 24 hours, get the fuck out. Because that's how healthcare is these days, right? It's a failure of the system. What should have happened is that she got stabilized, her medications balanced out, her sleep improving. Whether she wanted to go in, she was there voluntarily. That was the first problem. She was allowed to check out. Her husband, it honestly, who knows if it would have gotten figured out with the way this shit's such a mess, but if they would have gotten her medications regulated, all of these problems under control, then they would have been able to determine after, if they returned when she went home, that it was something environmental, right? If that is the way healthcare would have been, because that's typically how we would have done it back in the day when, you were allowed to keep people in the nut house, right? Now it's like it's like jail. You can't break in, fuck, you can't get the help you need from the place. But if she would have, and the proper processes would have been followed, then the next logical conclusion to any clinician, not researcher, would have been, this is something environmental. And they would have started looking at him and maybe doing a drug test and seeing if she had shit in her system that they didn't prescribe, and then start questioning her environment, not her. But that's not the way healthcare is anymore. We're going to blame the patient.
Yes.
did she say she was?
No.
Did she indicate whether she had any plan or intent?
No.
And as far as intrusive thoughts, did she speak about intrusive thoughts during that meeting?
No.
Did she tell you she was having horrible thoughts?
No.
She had previously used that terminology in your MyChart exchanges, correct? At some point?
I do remember the intrusive thoughts that she would mention. Intrusive thoughts. I don't recall horrible thoughts.
Okay.
In my chart messages.
As far as the intrusive thoughts, were they things that you followed up on in your telehealth or in-person visits? And was she able to articulate to you?
Yes. Yes or no? Sorry.
Was she able to articulate to you what types of thoughts she was having?
Yes.
What were they?
Intrusive suicidal thoughts.
So thoughts of harming herself or just wanting to die?
Thoughts of wanting to die.
At any point did she ever indicate to you thoughts of wanting to harm her children?
No.
So at the conclusion of this visit on December 13th, what was the plan?
The plan was to continue Seroquel 200 milligrams and Valium 2 milligrams.
Okay. And again, in this December 13th meeting, did you also indicate to her that she should engage with other services like support groups or partial hospitalization programs or CBT?
I did.
Do you recall whether you received any MyChart messages from her after that visit on the 13th?
I did.
So
I actually sent her a message on the 13th.
okay. So on the 13th, you meet with her at 10:30. At 2:27, you sent her a message. Why?
I wanted to send along some more ideas and information on what she could do to help herself feel better.
Because even though she was reporting sleeping better, she was still presenting with these depressed symptoms, correct?
Correct.
And so in the message you sent her on December 13th, it's actually a fairly lengthy message that talks a lot about cognitive behavioral therapy, right?
Yes.
And the benefits of it, and sends encouraging words.
Yes.
Does she respond to you on the 13th?
No.
The next contact you have with her, is that in a MyChart message on December 16th?
Yes.
And December 16th, 12:50 p.m.
Oh no, I apologize. The next contact with her, there was a telephone call on December 15th.
Okay. Was it with you or was it with a nurse?
It was with me and her husband and Lindsay.
Okay.
Do you notice a lot of these hospital stays aren't very long, so he has control of the situation? He's the one pressuring her to come home. Can't keep drugging her if she's in there, right? Maintain control. Not even 72 hours. The one was 24, the other one was 48. I don't even think 72 hours has been hit. 24, 48 hours? Because it was a voluntary psych hold. She was able to leave on her own.
Sorry about that. So December 15th at 3:53 p.m., you have a phone call with them. And what did they report to you in this phone call? What does Lindsay report?
They inform this has been the worst day for Lindsay, is having persistent intrusive thoughts of suicide, no active plan, but both Lindsay and Patrick agree that higher level of care may be necessary at this time. Discussed options, they state they are likely to go to MGH ED as they have perinatal psychiatry as well as an inpatient psychiatric unit. Lindsay also deciding about McLean. This writer advised that they keep us posted and sign a ROI, release of information, so that we can communicate with treatment providers at higher level of care. Lindsay verbalized
Like, they have tried to paint her as a drug seeker. Everything that she is doing and saying is opposite of that. She's seeking answers and help. She's at her wit's end. She's even ready to go to substance abuse counseling after 2.5 weeks on Ativan as a nurse. Hello. What? I wish I was, like, I'm almost wanting to go to school for, like, paralegal. So I can sit here and go, no. Hey, right here. Let me show you something. Let me help you with your arguments. I just don't want to argue because I will lose my shit. I would love to do paralegal, though. This is, no. I can't wait for the defense to present their side. This is all prosecution. This is
standing in agreement.
So on this phone call that you had with them on 12/15, what prompted the recommendation that they go to the emergency department?
Again, they had described it as the worst day and was having persistent intrusive thoughts of suicide. And they were at the point where they were ready.
What specifically makes it the worst day? None of you have talked in detail to your patient to ask, and it's just like what I tell you when you go to pain management, right? What makes it more painful? Like, what can't you do? What limits do you have that, like, what tasks could you perform before that you can't now? How many flights of stairs can you climb? What, can you go grocery shopping? Can you drive? Can you shave? That I used to be able to do this. Like, give them something to chart. Because if not, you got nothing but air. What makes it your worst day? What is worse about, details? If you guys could chart in fucking, like, short text like we used to with the little, like, T9 fucking phones, you would. Like, you put as little information as possible to help people. It's great.
To get assessed for a higher level of care.
And was this different than some of the other communications that you've had with, or that you had with Lindsay Clancy over the course of the weeks?
I would say so.
Okay. And so you talked to them about the process of going to the emergency department and the potential for going to McLean for inpatient?
I recall advising them that if they were to go to their nearest ER, which would either be BI Plymouth or South Shore Health, the process would be that they would get evaluated, but if they were determined to need to go to a higher level of care or an inpatient psych, those facilities did not have inpatient psych units.
Okay, well, you're screening and screaming, anhedonia and depression, but have any of you treated it as postpartum depression? Where is that diagnosis? I haven't heard it. I've heard everything but. Why are you sitting on a stand saying depression related and then you think it's like manic? Why are we not looking at postpartum depression? What? Is there a different billing code? Hey, May, maybe you can do some research on that. Do they get a higher payment for these billing codes? Is the therapy more involved with these other complex cases? Because they're going to, maybe that's what it is. Postpartum depression typically resolves. The other one's a continuation of care, more payment down the line. Could be that. That could be a question. Exactly. Like, if we treat it as postpartum usually has an endpoint, right? Once hormones stabilize and we get through that period, things usually return to somewhat normal, or our new normal as a parent. But if it's a bipolar or something else, that's a chronic condition, right? Well, that's a billable forever thing. It's not going to resolve. You won't, you know what I mean? It's a dollar signs, profits over people type thing. Yeah. And there's a lot of questions to pose there. It could be the chronic versus acute thing, more billable hours down the line. And they already don't get enough for mental health payment. She sounds like she had a good insurer with Blue Cross Blue Shield. It wasn't a Medicaid concern. So there's also stuff like that, but greed, it could be greed. People looking at dollar signs and not resolving the issue. We're going to label her with something chronic, get her hooked on pharmaceuticals, get her bound to the industry, and here we are. Another multi-level marketing doctor to mental health drugs. Great.
So they may be sitting there waiting for a bed at any first opening in the state, which could be, up in, Amesbury or Newburyport. But that if they were to go somewhere like MGH has a unit called Blake 11, which is a psychiatry unit, and oftentimes they prioritize admissions from their own emergency department. MGH and McLean are also combined under the umbrella of what's now MGB. So sometimes if somebody presents to MGH ED and there's no beds at Blake 11, they might reach out to McLean and try to get them in to McLean.
So you communicated all of this information to them to kind of give them options on what the best course might be to get inpatient.
Yes, I summarized it in my note, but that's my recollection of the phone call.
Okay. And you're aware that that Ms. Clancy had been employed at Mass General as a labor and delivery nurse?
I was.
So they were familiar with that facility.
So I did ask, would you be comfortable with that?
And so then you were able to communicate with Lindsay via my chart that next day on December 16th, correct?
She reached out to me on December 16th via my chart, yes.
And she indicated to you on December 16th at 12:50 that she, after visiting the ER yesterday, I opted to remain outpatient and pursue the partial program at Women and Infants. And Women and Infants, that had been the program that you had previously recommended in Rhode Island, correct?
Correct.
She indicates, I'm waiting on a call back for them to schedule. In the meantime, I want to know how to proceed with my meds. Do you still recommend the 2 milligrams of Valium and 200 of Seroquel nightly? Again, it's making me sleep well, but still not improving my mood. So I will need.
You know what a popular mood stabilizer is for people is Tegretol, carbamazepine. I haven't heard any of these. Zyprexa is an antipsychotic that you use as a mood stabilizer. I don't know why you wouldn't go with Tegretol or something. Like, your choice of meds is even concerning. Because 2.5 milligrams of Valium is fucking nothing. It's nothing. It's like 1/4 milligram of Xanax, practically. Yeah, like, I don't understand. Like, I remember when, I had Harley. I went through some mood shit, but it was PTSD related. This is where it all started for me. So this is like I could have been this woman. And I think that's maybe why I relate so well to this case and why I'm so invested now. It's because I'm seeing the parallels to my own life. Because that's where it started for me. I was started on Paxil, started on Zoloft, and then I went on Depo and I was fine. For 8 years, I was great. And then all the Depo problems happened and we had to come off of that. I got spongy bones and it was like, fuck. That's when my problems in life began, is when I went off Depo. I was so stable. I felt so good after that. But they because I wasn't getting a resolution with the Paxil and the Zoloft, which is another thing I haven't heard them try to give her, is Paxil. They went up to Zyprexa. And when I was doing my research before I went into medicine, this is after HVAC, I was like, why the fuck are you giving me an antipsychotic? But this woman's got medical training, right? She's got the ability to ask questions. No, she went to school. And none of it ever worked for me. And by the time I got done and continued care, 5 years later, I had a list of 20 fucking meds that they tried me on. Same shit. Because there's no one-stop shop, right, for fucking meds. Well, it's because you're not treating the right condition. At some point when you go through a list of meds like this, it's not the fact that you haven't found the right combination yet. It's that you're not treating the right condition. At some point in time, you have to realize that you're spinning your tires in a muddy rut hole with 44-inch super swampers, and it's time to call the tow truck and back it the fuck up and go a different direction. That's what people don't learn, is that, it's okay to be wrong. It's the approach that you take with your patient on how you evaluate and explain that. And a lot of people don't want to take accountability. I think, maybe I was wrong. Medicine is, it's not perfect. It's a communication issue. And obviously these doctors have a huge problem with communicating. And she's at her wit's end. There's only so much you can expect a patient at their fucking wit's end who's out here crying and asking for help to communicate with you. There comes a point where they're at the end.
Need a refill on those meds, please let me know. So
And then
in
you
this
become a veteran.
particular
Fuck you and those
message,
meds.
she indicates to you that she was waiting to schedule women and infants, correct?
Correct.
Or were you aware that prior to that Letitia Dukes had already initiated the referral process for women and infants?
Yes.
And so on this particular message, she's kind of updating you, but also asking you if she should stay on the same track for her medication.
Yes.
And what was your response? So December 16th at 1:14.
I said, "Hi, Lindsay. I know Letitia may have called you yesterday about information about women and infants, so I hope you were able to connect with her. Target dose for Seroquel treating depression is 300 milligrams, so we can increase it to 300 milligrams if you are willing. Yes, continue the volume. Let me know what you think."
And why at this point did you recommend increasing now to the 300 after having recommended staying at 200 for the Seroquel?
The FDA recommended dose for treating depression, bipolar depression, with Seroquel is 300 milligrams.
So on December 16th, you continue to have messages with, my chart messages with Lindsay Clancy, correct?
Correct.
In any of, or do you know that she went to see her previous psychiatrist on that day, December 16th?
Yes.
And so in her messages later in the day at approximately 2:11 p.m., she indicates, "I spoke with my original psychiatrist after my ER visit, and she recommended adding 25 milligrams of Lamictal to stabilize my mood. Is that something you would agree with?" Had you ever talked with her about Lamictal before?
No.
Is it a drug that you kind of commonly recommend for people?
I do.
And was it something that you thought could be a good fit for this patient?
Yes.
And so in your response to her at 2:26 p.m., do you further talk about using it as a mood stabilizer?
Yes. I state absolutely lamotrigine works well for mood stabilization and depression. I talked to her about the side effects of it.
And fair to say those side effects are like rash and skin changes, fever.
Can we find out what the witness feels the side effects are rather than...
Why don't we let the question be, what was she told? All right? I think that's the proper question. So why don't you ask what was told or what was said or messaged to the defendant?
Can you tell us what you messaged her the side effects were?
So I recommended it needs to be a slow titration, meaning titration, increasing the dose due to risk of SJS, which means Stevens-Johnson syndrome, which can be a very serious rash that somebody can get. There's a higher risk of it if somebody takes Lamictal, which is why the FDA recommends such a slow titration, 25 milligrams for 2 weeks, 50 milligrams for 2 weeks, 100 milligrams. You can't really go quick with it. I also specified it can cause a benign rash as a side effect. So any skin changes you notice, you want to be sure are not accompanied by things like fever, malaise, pharyngitis, swollen lymph nodes. Also watch for a rash that is purpuric or tender. Benign rash would be spotty, non-confluent, non-tender, and no systemic features like fever. Otherwise, I find this medication to be quite well tolerated. Take with food to minimize any risk of GI, such as nausea. I can send this to your pharmacy along with the dose change in Seroquel. Any luck with hearing back from women and infants?
So the Lamictal, am I saying that correctly?
Lamictal.
Is that something that you would add to the Seroquel?
Yes.
And why would you add it to Seroquel?
They work differently. They have different mechanisms of action, and they can work well together.
And so at that point, on December 16th, do you recall kind of what the last version of the medication recommendations were?
From me?
Yeah, so at this point, you added a medication. So what was on the prescribed or recommended list for you, for her, as of December 16th?
So I asked her if she needed me to send along the lamotrigine, and she said that she had her psychiatrist send it along.
Okay, so, but as far as now what you know to be the medications that she's been advised to take, what are they at this point, December 16th?
Lamotrigine, 25 milligrams, Seroquel, 300 milligrams, and Valium, 2 milligrams.
And the Valium is...
Again, why do you have two different providers prescribing your psych meds from psych? You got a psych nurse there are people who take control of that, so that way you have one provider to coordinate all those medicines, so this risk of interactions and other things don't happen. You already don't communicate between these different offices. You've already established that. You have no release forms signed with each other. Nothing. This is how overdoses and shit happens. Wild.
Is that still a daily recommendation?
Yes.
At the end of that message that you just read, you asked her if there was any luck with hearing back from women and infants, correct?
Correct.
Did she respond to you in a message about what was happening with the women and infants? The next message at 2:33?
In 2:33, she said, unfortunately missed the call this morning from women and infants, but I request them to call back. I'm hoping they do so today.
Okay. And you said that you'd also learned in this exchange that her other psychiatrist had already called in the lamotrigine prescription.
Correct.
And then, did you have any further communication with her on 12/16?
I said, okay, sounds good. I hope so as well. And that was it.
When's the next time you spoke with her?
12/16 was a Friday, so I spoke to her on Monday, December 19th.
And again, did you speak with her via the MyChart messaging, or did you speak to her on the phone?
MyChart messaging.
And were you aware that on December 19th she had another appointment scheduled with Letitia Dukes for that morning?
Yes.
And in your communications with her via MyChart, they started at 11:04 a.m. on December 19th?
Yes.
And does she indicate to you in that message that she is starting with women and infants partial hospitalization tomorrow, meaning the 20th?
Yes.
And that she's concerned because she has an appointment scheduled with you already, and she's asking what she should do about that, correct?
Correct.
And what was your response to her?
So she has an appointment, but should be in the program. Should I call and cancel or reschedule because she thought the program would be starting her medication? I said, I'm so glad you were able to get into the program this week. That's great. So feel free to call and reschedule. The only issue is that I am on vacation next week, so it might be 2 weeks out that we touch base again if that's okay with you. Let me know what you think.
Okay. And her response at 1:24 that says, I think since I'll be followed by women and infants, that 2 weeks out will be okay. My only concern is potentially needing more Valium before that. I'm trying my best not to take it at night, but have still been taking 2 milligrams every other night. Can we refill that just in case I continue to need it, right?
Right.
So at that point, when she sends that message saying she needs the new prescription for Valium, was that in line with the recommendations you made for a taper of Valium?
I had recommended that she take it daily.
Okay. And so in this, she indicates to you that she's trying not to take it at night, but taking it every other night.
Mm-hmm. Correct.
And on December 19th, you respond, sure, no problem. When will you be out of Valium? And she responds, I'll run out tonight. And then you agree to send in a refill.
Yes, I wanted to make sure she had an appointment rescheduled with me, and then I would refill enough of the Valium to get to that next appointment.
Okay. And so did you refill the prescription based on what she reported she was taking, or what your recommendation was that she take of the Valium?
What my recommendation was that she take.
And so do you recall receiving a message on December 20th via MyChart from Lindsay?
I do.
And she reported to you that she had been discharged from women and infants that day, correct?
Correct.
And that they recommended she find help getting off the Seroquel, and that she was indicating that she'd like to taper the Seroquel.
Yes.
Did you respond that day or the next day?
The next day.
Okay.
Her message came in at 8:05 p.m., so I responded the next morning.
Okay, 10:57?
Yes.
And what were your thoughts about her report that she was discharged and the recommendation for tapering the Seroquel, or getting off the Seroquel, I should say?
I said I'm not opposed to that. However, I'm concerned she discharged you, as I do feel you could benefit from the groups and added support separate even from medication changes. In fact, if we're not going the medication route, I think groups and therapy are the treatment needed, as I feel the intrusive thoughts you've been having are nonetheless concerning, and I know they've caused you considerable distress. I'm also on vacation next week, so I'm hesitant to start a taper when I am not available to you for questions and concerns. Again, I'm open to starting a taper, but I want to be available to you as it happens. You mentioned you are connected to your previous psychiatrist. Would that be someone to consult as well?
And so when you sent this message at 10:57, were you opposed to the idea of tapering the Seroquel?
I understood that it was helping her to sleep, and I also understood that she felt as though she was still depressed. And she wanted to come off of it.
And in this correspondence back and forth on the 21st, was there any conversation about the lamotrigine and whether she took it as a mood stabilizer?
No.
As far as coming off medication, was that something that you thought might be a good option for her?
as I had expressed to her, I was hesitant. It could be done, but she would need a lot of what I would recommend to be group support, therapy, other types of treatment.
At that point, based on your interactions with her through the clinic, through all the messages, through the meetings that you've had, were you aware of whether she was getting any other support, like groups, other than Letitia Dukes and yourself?
No.
And this partial...
I apologize. Is she aware or no, she wasn't? She just said no.
Sure, if you could just,
Are you aware of whether she was?
I was aware it was recommended. I was not aware that she was interacting with any groups.
And the South Shore Perinatal Behavioral Program, you have groups that are offered through the clinic, correct?
At that time we did, yes.
And if she was attending groups through the clinic, would that be something that you would have access to or be noted in her records?
Yes.
And as far as your communications with her, did she report to you that she was attending any sort of groups or therapy at other places in the community?
No.
The only person you were aware of that she was communicating with was her previous psychiatrist, correct?
Correct.
And that's why you made that recommendation to consult with her?
Correct.
And what's your concern, or what was your concern for not being available to her while you were on vacation with a taper?
I wanted to be there to evaluate if the taper was going okay, if she was suddenly having a hard time sleeping again, so maybe I could recommend that we go back up, or, just to reassure her, to be there for her while this was happening.
In your prior communications with her, she was very communicative with you about symptoms, about issues, about concerns, correct?
Correct.
And if you're on vacation, are you responding to my chat messages?
No. There would be someone that would respond. It would have been my nurse, and they would have consulted with the two other, and Julie, believe her last day was the 22nd, but they would have consulted with the other NP there, but I would not be available, no.
And you were invested in this patient's care, weren't you?
Yes.
So on December 21st, after you made that recommendation that she not start the taper while you weren't available or consult with her other psychiatrist, did you get a response from her at 3:57?
On December 21st?
Yes.
I see 3:47.
Oh, I'm sorry. That's what I meant to say.
Okay.
So 3:47, she responds back to you, correct? And gives you some more information about the women and infants recommendation?
Yes.
And it reads, the psychiatrist at Women and Infants recommended a more general mental health, PHP, partial hospitalization program, right?
Correct.
Such as the one at McLean, which I'm open to. I'm also looking to schedule with a CBT therapist in Duxbury. My other therapists have appointments this and next week, so I can follow up with her too. How would you recommend starting the taper? I will need smaller pills, as the ones I have now are all 300 milligrams. Right? That's her response?
Yes, she says her other psychiatrist does have appointments.
Okay. And in the meantime, she had also sent an email to the clinic. Are you aware?
None of you have asked why she has multiple mental health providers. This is not normal. I understand that you're a specialty center, but one of you needs to take control of the meds. Who is the primary on this? This is not established anywhere. Who's the primary? Like, I have a list of fucking questions that I wish I could email that defense attorney. Ah!
I'm not aware.
Okay. Do you know if she spoke with the nurse at some point on the 21st?
Yes, I asked my nurse to call to, again, go over the risks of tapering, which could include worsening of mood, worsening of sleep, verify that this was really something she wanted to move forward with, remind her that I wouldn't be there.
Okay. And on
See, and that's the thing, Nikki. That's like irresponsibility of multiple providers. Not a single one of them have release forms signed with each other, nor have they testified to the fact that they even asked. Every provider I have ever had, when you establish care, they want your records. I don't know what medical forms you... Are you a doc in the box? Is this a fucking joke? You don't want health records? You don't want to establish patterns with your patient? You don't want to establish your patient? I am so confused here. Like, listening to this testimony, I just hate healthcare. I should have never left working with ventilating buildings. I should have never went to ventilating humans. Never. This just exposed a whole, like, it's the bane of my existence. Like, I hate this shit. I know lab techs that know better than this. I know people whose job it's not even is to know this business that know it better than these fucking people. And can do it better if you would just get the fuck out of their way with your red tape and ego. Like, seriously. Just sign the fucking shit that the nurse asked and get the fuck out of here. You know, like, that's, honestly, that's why nurse practitioners make better healthcare practitioners, but I'm still disappointed in a lot of, like, failures to do any research on your patient. Like, what are we doing? And it boils down to time. The insurance companies dictate how much time we can spend with a patient. They need more time, but the insurance company's like, I'm not paying you, and you got another patient, you can't work for free. There's this laundry list of issues. I see it for what it is, but you can't neglect your fucking... Don't take on more than you can chew. Don't take on more patients just to pay the bills if you can't fucking provide care for them, I guess is what I'm saying. Right? Or plan on working in your free time. Or learn to manage shit with what you got. Or fight for Health 3.0, where you get paid a lump sum by the insurance company to manage that fucking patient for that condition that you diagnosed, because that's what the payment's for. And you better make sure you can clinically back it up, because that's how it should be. That would lower so many healthcare costs, because doctors could actually get their patients to, like, reduce their weight, change their diet over time, because that's what it takes is time, and insurance companies want results now.
December 21st, 2022 at 4:26 p.m., you respond to her in the MyChart message, right?
Right.
And
Yeah, right.
you had
Who the fuck
expressed
prescribes
reluctance for the
meds
taper,
without
but ultimately did you provide
collaborating?
her a plan for taper?
Right. I said, I know Nicole reached out to you and she relayed that you would like to proceed with the taper. I'm sending as 100 milligram tablets, 200 milligrams, 2 tablets for 4 nights, 100 milligrams, 1 tablet for 4 nights, 50 milligram tabs, half tablets times 4 nights, then off. Let me know if any issues.
And is that a standard or slow taper off of Seroquel being at a 300 milligram dose?
Considering the fact that she had only been taking it for a few weeks, yes. If she had been on it for months, I would have done a slower taper.
And in addition to giving her that plan, you also had the nurse provide her with some information about DBT groups, correct?
Correct.
And what's DBT?
Dialectical behavioral therapy.
And how's that different from cognitive behavioral therapy?
Dialectical behavioral therapy, there's certain tenets to it, like emotion regulation, distress tolerance, interpersonal communication. There's a lot of skills to it. It's a very skills-based treatment. So we had recommended that as an additional support.
And the next time you had contact with the Clancys, when was that? After December 21st?
I believe that was my last contact with Lindsay.
Okay. As far as the perinatal behavioral health clinic at South Shore, you're aware that on December 30th, Patrick Clancy called in about his wife.
Correct.
And that he spoke to a nurse, Katrina Melanson.
Yes.
And the record reflects that he reported that she was safe, right? But she'd like to go to McLean.
I do recall that.
And he was advised to take her directly to the emergency department. You can't just go there to McLean, right?
Right.
In your experience.
In my experience.
And that he said he didn't want to waste a day in the ED. Is that your recollection of the record?
That is my recollection of the record.
And that he was looking just to get the bed that was offered the last time on December 15th.
Yes.
And it's fair to say that that's not how the process works?
They do not hold beds for that length of time.
Okay. And so then he was advised to take her to the emergency department or call 911?
Correct.
And was that the last contact that the South Shore Perinatal Behavioral Health Clinic had with Lindsay Clancy?
Yes.
You were never advised or got any messages from her after she went to McLean, did you?
No. We did check.
Okay. The answer is no. Go ahead.
Did you learn anything about her course of treatment at McLean after the fact?
We had been wondering if she would come back to us. We did review the MASS PMP, which is sort of a log of controlled scripts, and we saw that she had medications filled from her previous psychiatrist, Dr. Tufts.
And that would have been...
No, object to move to strike. It's not responsive to the question about McLean. She's now talking about...
No, overall.
So the MASS PMP, what is that?
It is a database that shows when patients fill controlled scripts such as benzodiazepines.
And as a prescriber that has a DEA license, you're able to review that information for any patient?
Yes.
And so after the 30th, when the call came in about going to McLean, you were able to identify that she was prescribed additional medicines by a different prescriber?
Yes.
And she never came back to the clinic?
Correct.
During all of your interactions with Lindsay Clancy, did she always present with clear linear thinking?
Yes.
Was she able to express to you her concerns and ask appropriate questions when necessary?
Yes.
And was she able to advocate for herself and express that she had some knowledge base about some of these medications?
Yes.
And at no point during the time that she was your patient or that she was at the clinic, did she ever indicate that she was had a plan to kill herself or harm her children? Did she?
No.
Thank you. There's nothing further.
All right. Counsel, can I see your sidebar?
I'm such a nosy bitch that I want to know what's being said during this time. What are they saying? I think it's about the access to the medications through database through the
I'm going to
database.
excuse you till around 2 o'clock. Same instructions, the research, talking about this case, I hope everybody has a nice little break here. We'll see you back here right around 2 o'clock. Okay?
Court, all rise. Students, notebooks, face on chair, please. This way.
That's from Angela, so just so you know, I might have to do something because they won't let me read.
Okay.
She's doing the process.
Wow, look at this. 94% of people believe company culture is important.
All right, so we'll be in recess on this matter till around 2 o'clock. Okay?
I love this AP broadcast because they cut through everything.
They're lined up.
This court is back in session. You may be seated.
All right, we ready for the jury? Okay. Yeah.
Court, all rise. Jurors enter. This court's now in session. Please be seated.
Your Honor, for the purpose of the record, we return back to the trial of Commonwealth versus Lindsay Clancy. All parties are present, including the 18 jurors.
All right, thank you, Madam Clerk. Mr. Reddington?
Thank you, Judge. Good afternoon.
Good afternoon.
Your Honor, just a couple of housekeeping matters. I have the medical records from Women and Infants Hospital. I thought I offered that as an exhibit, but it's only marked for ID, so can I offer that now?
Commonwealth, any objection?
I have that we did mark them as Exhibit 220.
Yeah, I don't, it just says Exhibit F, though. That's why I usually mess up on those things.
There was another smaller packet that's not in a binder that council offered yesterday that's been marked as Exhibit 220.
There, it's up there.
Okay. All right, why don't we keep that marked for identification? If for some reason there's something different between Exhibit 220 and the identification, we could enter it. Okay. All right, if you need to offer anything additional, just let me know.
Great, thank you. Thank you, Don. The other thing, Your Honor, that what I would ask is that there has been a lot of reference to the Diagnostic Statistical Manual 5TR, especially as it relates to bipolar and related disorders. There's not an awful lot, but there's like probably 15 pages of single-space typing, and it's really hard for people to absorb it. I'd like to offer that section of the DSM just as an exhibit, so if somebody wanted to look at it, they could.
I would object. We have witnesses to testify about that.
All right.
All right.
Why don't we mark that for identification? I guess
That's my book, though. I need it.
Oh, I don't want to take away your book. But why don't we can readdress that.
Okay, sure. Yep.
In regards to that, and if we're going to do it, it would just be portions of the
Yes,
DSM
we'd only
file.
do that one section. Right?
But we'll see. Well, I'll give the Commonwealth the opportunity to be heard.
Okay, thank you. So you, in the course of your employment at the South Shore Health, is it?
Yes.
How many times did Lindsay meet with you?
Meet with me was 3.
And how many times did she meet with, does that include medical?
Yes, I saw her twice, telehealth once in person.
And do you know how many times that, you know that she had a psychiatrist that had been treating her since end of September, early October, right?
I knew that she had a psychiatrist that treated her in September.
And who was that?
Dr. Tufts.
And did you know that she continued to see Dr. Tufts through October, November, December, the same time that she was reaching out to you guys for help too?
I was aware she took the Zoloft in October. I was not aware she was still seeing Dr. Tufts in November. And I
See, right there. No fucking communication. Had you doctors had mutual releases, you could have been... Was that intentional? Did Patrick have something to do with it? God, I have so many questions.
knew she called her in December.
You would agree with me that young woman came to you people for help, right?
Yes.
Okay. And she was very, very forthright. In other words, if you wanted her to sign a HIPAA form, she'd sign it, right?
Right.
And she would answer your questions to your perspective in an honest fashion.
Yes.
You didn't really hide anything.
Nope.
She told you all about the medications that she had been on and her fears and concerns about the medications, right?
Correct.
She described for you, as District Attorney brought out, what she felt her symptomology was, including suicidal ideation, worrying about suicide, feeling heavy, lethargic, you can't get out of bed, all of that stuff, right? Correct?
Correct.
And one of the things that you had left us with towards the end of your testimony is the fact that you were very willing, if you will, to work in tandem with other providers. In other words, you were concerned about being able to get information from other providers that had been dealing with her, treating her, right?
I'm not sure I understand the question.
Did you talk to Tufts?
No.
Did you ever get access to Tufts' medical records?
No.
Do you know how many times she saw Dr. Tufts?
I do not.
Would it surprise you if I told you that she saw Dr. Tufts 14 times in the time frame of October, or the end of September, October, November, December, and then January, 4 months?
Yes.
And that's 14 times plus the 3 that she saw you. Is that right?
Yes.
So that's 17 times that this young lady had access to healthcare providers for her mental health issues, correct?
Correct.
And that would be within a compressed period of time. I know it's the last week, I believe, in September, but October, November, December, and then January, right?
Yes.
And during that period of time, you're aware that she was provided many, many, many prescriptions for antipsychotics, selective serotonin reuptake inhibitors, benzodiazepines, all of that, right?
I'm aware she was prescribed other medications.
She was what?
Prescribed other medications.
Did you ask what other medications there were?
Yes.
And did she tell you?
Yes.
Did she tell you who prescribed them?
Yes.
It's pretty easy to get a list from CVS, right?
Yes.
So if she told you who prescribed them, would you not question her seeing another provider? Did she write you a 4-month prescription? What? You're getting sued too. Oh man, he just nailed that. With those questions, with that line of questioning where he went the other way. If you were aware that she was getting these prescriptions and who prescribed them over this period of time, at what point in time were you going to question, where are you getting these meds? And when are you going to get records and take some accountability for what you're prescribing? And are you, oh my God, are you reconciling the meds? I mean, like, what are you doing? You know better.
And did you have any difficulty determining who was providing the prescriptions for all of these medications?
No.
And did you know that, in fact, it was Jennifer Tufts that prescribed the sertraline, September 15th of 2022? 30 count, 25 milligrams, was Jennifer Tufts. You knew that?
I did.
You know that Jennifer Tufts on October 21st, a 7 count of lorazepam. You know that?
I did.
And 5 days later, Jennifer Tufts prescribed on October 26th hydroxyzine, 25 milligrams with a 30 count. Did you know that?
I did not know that.
Did you know that on the same day, Tufts prescribed 30 count of lorazepam? Did you know that?
I would have known that, yes.
I wasn't-
Checking the PMP for controlled substances, yes.
You do recall that you checked with it?
Yes.
When you download, do you download that information and kind of put it in the file, save the file?
No.
So is this your memory that you believe that you checked with PMP?
I do routinely check the PMP.
You might routinely check, but did you check?
Yes. Yes, I did.
You don't download it, you don't keep it with the medical records, right?
It's a box you can click in the medical record and you can check that you reviewed it.
Okay. Is it in your medical record that you reviewed it?
I'm not sure how it would have gotten printed out. It doesn't like go into my note, but it is a box that I would have
Perhaps
checked
in a
it.
box in the computer?
Yes.
Okay. October 26th, buspirone, 5 milligrams.
What you would have charted is that you consulted that and reviewed it and saw that the patient was recently admitted and or saw Dr. Tufts' prescription filled, and you would have charted that in your fucking notes. Did you? Because you should always list it somewhere if you're not printing it out. Just because it's a box that you check, it means yes, I did, but you should confirm what you saw. This is why. This is why, because you can't verify for a fact other than checking a box that you did, but you could back up your testimony if you charted it in your fucking chart notes.
30 count, same day by Tufts. You knew that?
Buspirone.
Yeah.
I was not sure that it was Dr. Tufts that had recommended the buspirone.
Okay, so if I suggest to you that the prescriptions that we have in evidence on the chart indicates that on October 26th, Dr. Tufts prescribed a 30 count of buspirone, would that either refresh your memory or would you accept that as being a medical history?
I would accept that.
Okay. And what is buspirone?
It is a medication used to treat anxiety.
Okay. And lorazepam, what is that?
Benzodiazepine.
And hydroxyzine, what is that?
It is an antihistamine medication.
And lorazepam, again, prescribed on October 21st as well as 26th by Tufts. That's the same thing you just told us what lorazepam is, right?
Yes.
Sertraline, of course, is Prozac, is that right?
Zoloft.
Zoloft, Prozac, they're both SSRIs, right?
Yes.
So from October 21st up through November 9th, she was prescribed all of this group of drugs until she saw a Kavon Izadapana, Izadpanah. Do you know who that person is?
They work in the emergency department at South Shore Health?
All right. And that would have been on November 16th when she went into the emergency department, right?
Yes.
Prescribed trazodone, 50 milligrams, right?
Yes.
And then she started to consult with your clinic around the 25th of November. That would be around Thanksgiving or so, correct? November 25?
I believe her first visit with Julia was November 21st.
Okay. So what I'm saying is that it was around that time in November that she started to consult with your clinic, correct?
Correct.
You know that she was referred to your clinic by her mother-in-law, Pat's mother, who was a labor and delivery nurse.
Yes, I am aware.
Referred her to Julie Paul, who kind of stepped in for a very short period of time to try to help out, right?
Yes.
And then Julie left, went to New Hampshire to continue her work, and you picked up on November 30th of 22. Is that right?
November 29th.
On November 30th of 22, you wrote a script for quietapine, 30 count. Is that right?
Yes.
And what is quietapine?
Seroquel.
You also, a week later, wrote a script for diazepam, 5 milligrams. Is that correct?
Correct.
And then the next day, you wrote a script for, December 6th, you wrote a script for diazepam, 5 milligrams, right?
Correct.
December 7th, you wrote a script for diazepam, 5 milligrams, right?
Correct.
December 7th, again, you wrote a script for quietapine, 30 count, right?
I would need to check my...
You can look at anything you want. If
Okay.
you have your records, feel free, please.
Okay. You said
Yeah, it would be
December.
December 7th. And I'm looking at quietapine, 30 count of 100 milligrams.
I don't believe it was a 30 count of 100 milligrams.
Do you remember writing quietapine script for 100 milligrams?
I do. I believe the quantity was 22.
22, okay. So on December 7th of 22, you wrote a script for quietapine, and forgive me, I'm sorry, what is that again?
Seroquel.
Seroquel, for 100 milligrams, right?
Yes.
And why did you write the script on November 30th for quietapine, 25 milligrams, and then about a week later increase it to 100 milligrams?
On November 30th, I had anticipated utilizing it over a 4-week course of treatment for sleep and anxiety. But her clinical symptoms, presentations changed, and we opted to use it for mood stabilization.
And who's we?
Me.
Okay. And were you working with anybody else, any psychiatrists or anybody?
No.
So when a person comes to your clinic as a woman who has recently had a baby or is within that postpartum range of time and presents with the symptomology that she presented, is that something that would give you cause for concern? Suicidal ideation?
I in no way want to minimize what Lindsay experienced, but it's common for us to treat.
It's common to treat women in that
Yes.
fashion that are postpartum?
Postpartum who may have suicide. Oh.
Keeps cutting off the witness before she gives an answer. May she complete her answer?
Sure. As I've said before, let's only talk one at a time. You finish your answer, and then
Blue
we'll go to the
Chloros
question.
Blue Shield.
Her symptoms were serious, and it's not uncommon for me to treat women with serious symptoms in the postpartum period.
Okay. 2 days later, you prescribed 8 count, 5 milligrams of diazepam. Is that right?
2 days from December 7th?
Yeah, it was December 9th.
December 9th. Yes.
4 days later, you prescribed more diazepam. Is that correct? December 13th?
Correct. That would have been 2 milligrams?
Yes. And then jump ahead to December 19th, you prescribed 14 count, 2 milligrams of diazepam. Is that correct?
Correct.
And then December 19th, you prescribed 300 milligrams of quietapine, 30 count, right?
Correct.
And that was on December 19th. 3 days later, on December 21st, you prescribed additional quietapine, 100 milligrams, 14 count, right?
Correct.
And then 1 day later, you prescribed more quietapine, 25 milligrams of 14 count, right?
Correct.
As far as your prescriptions continued on, if we can jump ahead, you continued to treat her, and on January 13th, you prescribed 2 milligrams of diazepam, 7 count, right? That would be on January 13th?
I did not prescribe that on January 13th.
All right, if I suggest to you that Rebecca Jollotta has a script for January 13th of diazepam, that doesn't refresh your memory?
Would it
Right.
would it have been a script that I had sent previously that hadn't been filled at the original date?
Well, I believe the records would indicate that we'll make a note of it, January 13th, diazepam. How about January 16th? Do you recall prescribing diazepam to her, 2 milligrams, 3 count?
No.
Diazepam on the 19th of January, 2 milligrams, 14 count.
No.
No? So you're not able to prescribe medications, or somebody else can't use your name, right?
Right.
Okay. And you have the DEA license to prescribe medications, correct?
Correct.
Now, one of the things that you went through was a lot of, obviously, it's a little confusing with the names of the various drugs, and the district attorney said to you blithely, she said, well, she's a nurse, so she knows what those drug names mean. Do you recall that question?
I do.
Yeah. And you just said yeah, right? Mm-hmm. So you're assuming that a woman who gets her RN at the age of 24 in a 1-year program and then works for 7 years as a labor and delivery nurse is familiar with these names and what they are, what drugs they are?
She seemed to be familiar with them. Yes, she understood.
Did you
She
know
should
that
be
she
somewhat.
was Googling 60, 70, 100 times a night?
Okay, listen, Pops. Hold on here. Do you know how many times we Google a shift? What the fuck is that? It often comes about in our reading of a patient's chart, because that's what we actually do. I guess we're the ones who read those charts that the doctors don't. I guess that's us. But we absolutely Google the fuck out of things. That should not be argued from that angle. Poor argument. Poor argument. He needs to pick a different angle for that argument. That one ain't it. They're going to blow a hole through that.
What benzodiazepines are, what Seroquel is, what all of these medications are?
I did not know that.
Did you ever ask her where she acquired what appeared to be, apparently to you, her ability to know what these medications are?
I'm sorry, I don't understand the question.
Well, you wouldn't know the medications that a labor and delivery nurse uses when they're helping a woman who's giving birth, would you?
Not necessarily.
Okay. In any event, one of the things that you left us with is the fact that you were very, I think the word was invested in Lindsay Clancy and were concerned about her treatment, right?
Correct.
You knew that she had gone to the Rhode Island program for Women and Infants Center, Behavioral Health Day Program in Providence, Rhode Island. You knew that, right?
I did.
And you basically gave her the referral. You didn't make the referral. I think it was Latasha Dukes that might have done that.
Correct.
So you were aware of the fact that a recommendation was made to Lindsay that she reach out to someone else for help, right?
Lindsay made me aware of that, yes.
And she needed help, didn't she?
Yes.
And she went to Women's and Infants Hospital on December 20th, right?
She did.
And was she treated at Women and Infants?
I don't believe so.
Why not?
I wouldn't want to speculate or assume, but it seemed to be her intake appointment.
Her what?
Her intake appointment.
Okay.
Again, NP, if you would have requested the records from the hospital, you could have.
So without assuming or speculating, you referred her to this provider, right?
Yes.
So you have this woman who you know has been seeing Dr. Tufts, a psychiatrist, right?
Right.
You knew that. You didn't.
Mama Jones. Psych ain't a part of fucking respiratory either. But we read charts. We have to know the general idea of meds, the drug classes and pharma. Yeah, we do take pharmacy courses, and we do have to know drug classes and common meds in it. We do test on it. Yeah, we got to be familiar with them. Absolutely do. All of us do. I don't have shit to do with any of those fucking meds, and I still have to know general knowledge. I absolutely do in pharm class. But those are pretty general meds. And when you read a chart for 7 years of women coming in to give birth and they're on medication, there is going to come a point where you go, what the fuck is that? I ain't never heard of quetiapine, and you look it up. We use Google a lot during a shift. That's what I was getting at. Do you work in healthcare? Just out of curiosity. Because that's how it happens. You gain a lot of extra knowledge because you read your patient's fucking chart. And you're like, what the fuck is that? I ain't never heard of that. Because you got Google right there. You learn a lot of extra information by reading the patient's chart. RN, yeah. So you know these things. And for 7 years, you're reading the patient's chart and you didn't come across one woman who dealt with psych history, past medical. You didn't read PMH, meds, home meds, anything? Exactly. And I get where you're coming from with the 1-year RN program. And I really question that, as I'm sure you do too, right? That's a red flag. Can we get the name of that program so we can look into that? We all in the healthcare industry also have some further questions, right? Because we all know that labor and delivery and babies are really complex, and most of us run either to med surge, to the ICU, to the ER, and we don't want nothing to do with the babies, right? Right. Yeah. So I'm gonna maybe guess she was more of an LPN. I really question this program. I'm and I am there with you on that. But we all know that we learn a lot of things on the job that we have nothing to do with our fucking job. That's why we're so much better than the doctors, because we read things and try to figure out what they fucked up, right? But the 1-year program, Jesus Christ, it takes, 8 months to be a CNA? Huh? Exactly. So I have some questions on that, like this nursing program. So maybe we'll write that down and dig into that question. Maybe we need to tell him that you need to, call up her nursing school. Have them fucking testify, because America wants to hear from that program. Like every healthcare worker. Yeah, but Tanya, I definitely feel that the husband was doing a lot behind closed doors, and I feel that they were over medicating her without her knowledge, and it was interfering with this. There's a lot of unexplained reactions to these medications that aren't typical. You don't typically see that kind of reaction with that low of a dose in fucking 2 days. Nah, that takes a lot. God damn it. Where is the down button, bitch? It takes a lot longer for that to build up for you to react that way. Think of Chantix. If people didn't go crazy and have these. Chantix is another, okay, so that's a good drug to use as an example. Chantix caused a lot of those same, that's where the black label warning came from. It caused a lot of those exact same symptoms that she's complaining of. It is a type of psych med. But that's one of them that could do that. Yeah. So if you stop and think about that. But I'm definitely going to question here. Let's write this down in our overall questions here. All right. We're going to dig into that one. I like that. Good catch. Good catch. Yeah, and if Chantix can do it, then you know that some of these meds did, but it didn't happen with just 1 or 2 pills, right? There was a taper involved, and there was, a little bit more. Now, I did like Chantix. Chantix worked great for me. I didn't give a fuck about not quitting cigarettes or about quitting cigarettes. I got a little bit of my stomach upset because it's just like a psych med. It's absorbed in the gut, but I didn't have a bad reaction to it. I was able to tolerate it. And I was in the best fucking mood of my life. It was like Depo. Whatever's in that shit worked good for me. Like I said, not every med is bad for every person, but you do have to be aware. Educate your patient. Now that Dr. Tufts, that's the last thing that chick did. She never educated a fucking thing. That's why this woman is running around like a chicken with her head cut off looking for research and information. They absolutely could be. He could be logged into her portal pretending to be. I think that he was manipulating everybody and everything in an effort to get her committed so he could divorce her and run off with that doctor. And I think they were in on it together. I think that's exactly how I feel. Yep.
Get access to Tufts records. You didn't know what Tufts was doing, but you knew that for a period of time before she saw you, she was dealing with a psychiatrist, right?
Yes.
You knew that she was a woman who had just given birth like 5 months ago, right?
Yes.
You knew that she was obviously in trouble. She was sick, right?
Yes.
You told us that she was suffering from, and your words were, a mental health illness that was very real. And you told her that this will get better. And that was in December of 2022.
Yes.
So when you referred her needing help to this women's and infants program in Rhode Island, and she went because that's what she was told to do, what happened at Women and Infants program?
I can't speak to what happened at Women and Infants.
Why not?
Because I was not a part of that assessment.
What does that mean?
I did not see the assessment and speak with Dr. Diaz.
Why?
Lindsay had informed me that she was going to be at the program for 2 weeks.
She was hoping to be at the program for 2 weeks, right?
She told me she was going to be at the program for 2 weeks.
But she was turned away after about 8 hours of sitting there in an assessment and sitting in a group session. And she was turned away because of their concern that she was suffering from, well, let me ask you, what was their diagnosis?
I'm not sure.
Did you ever find out?
I have not.
Does it matter to you as a treating person that, I think your words were, is invested in Lindsay Clancy's care at that time? Did it matter to you why she didn't get accepted into the program?
It did.
Why was it?
I do not know their diagnosis.
Did you know that she had been diagnosed?
All of these things could have been answered if you requested the fucking medical records.
You have different diagnoses, right? Like general anxiety disorder or general anxiety, GAD, and then you have, is it a differential? Is that what it's called? Mm-hmm. What does that mean?
Yes. It means a differential in medicine could be patient comes in with a cough. What are your differentials? Differential might be bronchitis, pneumonia, strep throat. So it's different things, different diagnoses you consider.
Did you know that, in fact, they wouldn't accept her into the postpartum program because of their concern that she had been over-medicated by drugs, and they wanted to find out?
I can't speak to that.
Did you know that she was diagnosed as diagnosis depression due to adverse drug effects?
I cannot speak to that.
Do you know, invested as you were, that on December, strike that, on December 20th, the very same day that she had finished being evaluated, woman you were invested in, had been evaluated by Dr. Diaz that you recommended or you mentioned, that in fact, looking at the exhibit, that they recommended tapering Seroquel, starting 200 milligrams tonight, follow up with outpatient provider of note. We attempted to reach current outpatient provider Rebecca Jollotta, but did not receive a call back.
I never received a call from Women and Infants.
So this medical record from Women and Infants saying that they called Rebecca Jollotta and never got a call back, your memory is that they never called you?
They never called me. I absolutely would have called them back.
Okay.
They absolutely would not have charted that they tried to reach out to you during a matter where they're feeling that a patient... Are you fucking kidding me right now? You're answering the way that you are because you don't recall shit, because that's a malpractice lawsuit. Oh, fuck. You got 2 doctors prescribing. I don't even know fucking shit about this case. And from a healthcare angle, I mean, housekeeping, I'm sure they could tell you that this is wrong. This is so wrong. And it's happening to so many in this country every day.
Well, regardless, you never talked to anybody from Women and Infants, did you? Whether they called you or whether you reached out to them being invested?
I did not. I know our program re-referred her a few days later.
I'm going to offer this now, Your Honor, I think just...
It's already in it.
Yeah, I know. We'll just...
We've marked,
it's just certain pages. We can clean it up.
well, I'll allow, we'll keep it as an exhibit for identification. We can double check, make sure the pages that have been referred here are contained within, is it exhibit 220?
Yep.
And if not, then we can admit the second.
Okay, thank you. One of the things that is a takeaway from your treatment of Lindsay is that she was, I think your words were that she was scared and thought that starting these drugs, the drugs, it was scary, were her words, right?
Yes.
And at no time did it occur to you that Lindsay was doctor shopping or trying to get drugs. She was trying to basically get off drugs, right?
Correct.
One of the things that you had mentioned is that the Good Moms Have Scary Thoughts book is something that you guys would give out to women when they would come into your program?
Yes.
And hopefully it would be a good source for them to read things and maybe get some comfort from it, right?
Yes.
This is not, in your opinion, something that is indicative of like being a smoking gun.
No.
Police officer would seize it in the search warrant.
No.
This is something you guys provide people to just help them out, right?
Yes. Yeah.
And just a couple of things. So on November 17th, she had an office visit with you. Is that correct?
Not on November 17th.
Okay. And the U.S. South Shore Medical Center, right?
Yes, that may have been her PCP.
Okay. Is that her PCP? Is that a person that would be under the umbrella of the South Shore Medical Center?
Yes.
Would that be Kimberly Tocchio?
Yes.
Okay. So you must have read Kimberly Tocchio's records, I would imagine, right?
Yes.
And you know that she was seen, record indicates that she was seen by a psychiatrist, and this would be November 17th note, started Zoloft 25, which was then increased to 50 milligrams, right?
Yes.
And she took the Zoloft 50 milligrams for one night and was unable to sleep and was discontinued because of the effect that it had on her, right?
Yes.
Now, one of the things that you had mentioned,
You are not going to have a reaction. She feels like one of these creators that we know out here who's paranoid to take any kind of medication. Serious. That's a ridiculous fear, but it's a fear. Why is it a fear would be my question as any kind of mental health provider, because it's always why. Why? What's causing this? Why and what? What's the root? Why are you having all this fear of this medication? Should be any providers like, what is this unreasonable fear? That's usually a traumatic response, you know, like, why are you having all this anxiety about this like, what is causing this? Did anybody ever ask the why? This whole trial has got me asking, what is her why? Why didn't you do this? Why? That's what this whole thing is about. Why for me? Lots of whys. But there's usually a reason, right? Usually there's somebody you know that overdosed, or, you know, I have a feeling it's her husband is what the answer is. My husband is, you know, if you were to ask her, the pattern of my husband would probably be her answer, right? There's just unreasonable fear all of a sudden. He's the one that they keep referencing every other damn time. If you would just slow down in that 2 extra minutes of interview time with the patient, you would get there. There'd be all those red flag statements that you could help. Like, if you, I don't know if you, like, any of you considering going into healthcare, you don't have a lot of time with your fucking patient. You need to do a lot of information gathering in a short amount of time. When you walk in that room, you need to know, is the patient happy to see me, number one? Because then you got a hostile patient. Number two, it's nice to read their occupation and their background, especially when I'm trying to describe breathing mechanics, because it's opposite of what you would think. And then in a baby, it's totally different. You know, and if I have an old miner or crotchety old farmer, I'm going to approach them a little bit more directly, not so smoothly, because they don't want to hear it, right? They want, just give it to me. So I do. You know, now if I got some gentle little old lady, I'm probably not going to be so gruff. Well, unless she was a freaking like drill sergeant in the army, you know, like I'm going to read the background of who I'm dealing with. That's important. You're trying to educate your patient, obtain their goals of treatment, and do all the things that are required by law in a 15-minute time period that you're fucking billing for. It's really hard unless you develop skills. That's why this job ain't for everybody. It ain't. And if you don't have the ability to do all of those things and satisfy your patient, get the fuck out of healthcare. Just go. Or refer them to somebody in your practice who is an educator. Offer those things, which is why we need to change the way that we bill for healthcare. ZDogg MD, Health 3.0. Do a lump sum payment. You manage that fucking condition. This is how much you're getting paid.
Is that it's important to determine, and you did have thoughts of possibility that she was bipolar. Is that correct?
Correct.
And one of the things that is contraindicated to someone who does suffer from bipolar, whether it's 1 or bipolar 2, is that you do not place them on a selective serotonin reuptake inhibitor drug, such as Prozac or Zoloft, right?
Correct.
Because it can have an effect on them, isn't that right?
Correct.
And what's the effect it can have on them?
It can cause what we consider rapid cycling, meaning you can swing from mania symptoms to depression symptoms relatively rapidly.
On November 21st, did she have a meeting with you all? If you recall, looking at the records, did she meet with Julie Paul?
Yes.
Okay. And she gave Julie a history of what she had been going through. Is that correct?
Correct.
And
This case is just an example of what so many women in this country are going through. You know, like how many other women are going, me fucking too. Oh God. That's what's really scary. There's so many manipulative men out there.
In that history and in her talks with Julie, she had disclosed the fact that one of the things that she did in November was took a marijuana gummy, one gummy, to try to sleep, right?
Correct.
And again, her medical tests, blood tests, urine tests, everything showed that she had no alcohol, no THC, nothing on board, but she still disclosed the fact that to try to get some sleep, she took one gummy in November, right?
Yes.
So again, she's reporting, trying to be honest with you people as a provider, correct?
Yes.
And the scales that counsel asked you about, you were talking about the depression scale, you were talking about the Edinburgh scale, and I think we all know that the Edinburgh scale is geared for an evaluation of a person, of a woman who is in that postpartum period, and you evaluate whether or not they are, as a result of being postpartum, severely depressed, right?
Yes.
And you indicated that at some point her Edinburgh scale was initially, what was it, 15, 17, if you know?
Initially at my visit, my first initial with her,
Yeah, what was her Edinburgh scale the first time you saw her?
17.
Okay. And that would be moderate?
Moderate.
Okay. And then she had another Edinburgh scale after that, correct?
Correct.
And when was that, if you know?
December 6th.
And what is EPDS? What does that mean?
Edinburgh Postpartum Depression Scale.
All right, so would you look at November 21st, please, which would be, so November 21st, she was administered a Edinburgh test, right?
On the 21st. That would have been at Julie's appointment. I don't have that in front of me.
If I told you that, well, on November 21st, it's a short period of time after November 17th, did they, whether it's Julie or somebody else, administer an Edinburgh test to her?
Yes.
And what was the result?
23.
That's severely depressed, isn't it?
Yes.
So in like 6 days, she decompensated from Edinburgh scale 17 to Edinburgh scale 23, right?
So she was 23 on November 21st.
Right.
And 17 on November 29th.
Okay. So when you see a patient that's come to you and has an Edinburgh scale of 23 and an Edinburgh scale a couple of days later, that would be, what was it?
17.
And what was it when you first saw it? You referenced it before, 17?
17.
Yeah. That's still pretty high, isn't it?
It's high, yes.
Would that give you pause in conjunction with the symptomology that she's referring to and self-reporting, what she's feeling? I mean, the fact that she has a 23 on the Edinburgh scale, which is very high, and then followed up a couple of days later by a 17, taken in conjunction with what she was saying her symptoms were. That's of a concern, isn't it?
Yes.
So on November 20th, which would be the day before that Edinburgh scale of 23, and the jury will have access to all these records, she was reporting struggling with postpartum anxiety, right?
I can't speak to
Okay,
that.
that's fair enough. We'll go to when you treated her.
Yes.
Did you have a chance to review Julie's notes at all?
I did.
Okay.
Yeah.
And when was the first time that you actually met with Lindsay?
November 29th.
Okay. Which would have been after Thanksgiving, obviously, right?
Yes.
And you would have reviewed the records up to that point, right?
Yes.
So one of the things that you would have reviewed was what she had indicated or reported to Nicole Harden Francis. Do you know her?
Yes.
And who is Nicole Harden Francis?
She's the nurse at our program.
All right, and this would be on November 28th that she was speaking with Nicole, the nurse. You read the report before you met with Lindsay on the 29th, right?
Right.
So you knew that she had been reporting panic symptoms, that she was disoriented, that she was forgetful, that she was not connected to her body. Is what she told her, right?
I would have to review that just to be accurate.
Right. I misread that.
That's correct.
Okay. And would you agree with me that symptomology of mania, especially when incurred or encountered by a woman within the postpartum period, that's one of the symptoms, is being disoriented, right?
Not necessarily.
How about maybe a little bit?
Could be confused if you're manic.
Yeah. How about forgetful? That's an issue, isn't it?
Not necessarily a symptom of mania.
Okay. How about not connected to her body? What does that mean?
I'm not sure what that means.
So if you have a patient who's coming to see you, who's indicated the day before that she has the panic symptoms, disoriented, forgetful, not connected to her body, wouldn't you ask her what she meant by that?
Yes.
Okay. So when you saw her on November 29th, you diagnosed that she had postpartum anxiety, right?
Mm-hmm.
Adjustment insomnia, right?
Correct.
And when you met with her, you noted that over the last 2 weeks, you asked her about how she had been feeling, and she said she was feeling nervous, anxious, and on edge, and she said nearly every day, right? That's November 29th? That would be under screenings?
Yes, she was.
I would give you a page number, but they don't give us page numbers. She told you, and you can pull it up if you have it there, that she was not able to stop or control worrying, and that had been for several days at least, right?
Correct.
And she was worrying and stressing about things, worrying about different things every day, right?
Nearly every day, yes.
Couldn't relax nearly every day. This is a questionnaire form that you have, right?
Yes.
Being so restless nearly every day, correct?
Correct.
Asked if she was annoyed or irritable, and she said not at all, sure, like she didn't believe that she was a person that would be irritable or angry with people, right?
Yes.
And then feeling afraid, as if something awful might happen, and she got that GAD 7 score of 14. Is that correct?
Correct.
So what does a GAD score of 14 tell you on November 29th?
Moderate anxiety.
And then you ask about in the last 7 days, trying to get a history. She denied, definitely not so much now, that she was able to laugh or see the funny side of things, right?
Right.
And that she was asked, is she looking forward with enjoyment to things? And she responded, hardly at all, right?
Yes.
Blaming herself when things go wrong, she says, yeah, some of the time. Yep.
Yes.
Anxious and worried for no good reason, yes, correct?
Yes.
Scared and panicky for no good reason, yes, correct?
Yes.
Then they asked if she felt sad or miserable, if she was a miserable person, and she said, no, not at all, right?
Right.
Did she indicate that on that date you gave her the EPDS Edinburgh test, and she had an Edinburgh score, as we said, of 17, right?
Yes.
All right. And then the medications that you prescribed to her, we've already got an evidence. The jury will be able to look at the actual scripts in the exhibit without going through every single day. The next time you saw her was November 30th, is that right?
I messaged with her on November 30th, yes.
Okay. And You indicated that if you're not sleeping well with Valium, no need to continue it. I'll prescribe a short taper. And you went on about tapering and 5 milligrams of Valium to 2.5 milligrams and no benzos. And
That was not on November 30th.
okay, does it say on the record, are you looking where it says patient message in the perinatal behavioral health program of South Shore Health, November 30, 2022?
Yes, I'm looking at the messages.
Okay. So is it a different date that you sent that message? It says November 30th on it, right? I just don't know internally if you guys have different.
Oh, I understand. Oh, at the top it says November 30th.
Yeah.
More specific, it'll say
Okay.
the dates, but the header will say November 30th, so I understand.
Okay. And basically, you indicated that you were going to send along information about bipolar 1 or bipolar 2, which actually would be what's known as a bipolar spectrum disorder. Is that correct?
Yes, that was on December 7th.
Okay, but it's underneath November 30th, so forgive me for looking at it that way.
Yeah, I don't know why.
That's all right, no problem. So one of the things with the mania that you refer to and that you talk about is excessive activity. Is that it? Excessive cleaning sometimes, right?
Sometimes.
Excessive exercise.
Sometimes.
Did you know that after she had Callan, that within a matter of a couple of weeks, that she ran a 5K?
No, I did not know that.
And that nobody wanted her to, including Pat, but she just had to get out there and run and did.
Objection.
No overrules.
You know that?
I did not.
Is that something that would be important to know? I mean, as far as whether or not a person is in that manic stage where it's post-delivery, and that's a significant artifact, if you will, of exercising, right?
It would have been something I would have considered.
Okay. And as I said, you were pretty much the only one that actually considered bipolar spectrum disorder of all the doctors that she had seen. You know that, right? Are you aware of that? All right, never mind. That's right. She's going to object. That's okay.
Okay.
So the symptoms that you noted were mania. It says mania characterized by exaggerated excitement, hyperactivity, and racing scattered thoughts, right?
Yeah.
So what is, go ahead.
Was that from my note?
I'm looking at the same thing that we've been looking at, which is,
Oh, the information I sent her on bipolar.
yeah, it says,
Yes.
hi, Lindsay, and then your note, right?
Your Honor, if I may suggest maybe showing the witness what he's referring to.
She has it in front of her.
I think I understand what he's referencing, but thank you.
If the witness has a problem in regards to that, and you need to look at some, just let me know.
Okay.
All right.
Thank you.
Thank you. If you move ahead to, I think the message portal or whatever it's called, on November 30th, it's captioned "Stopping Remeron." And then
Yes.
okay, you're with me. And it says, no, this would go to the fact that she was still not sleeping. It was a huge problem for her, right?
Yes.
And she told you in her message thing, no, the weird thing is I don't feel tired at all.
Correct.
And that's one of the things that you had told us earlier is a symptom, correct?
Correct.
A person that is not getting sleep but doesn't feel tired.
Correct.
What is the symptom of?
It's a symptom of mania that we look for.
Okay. And when we looked for that mania, did you notice that? And did you factor that into your diagnoses?
Yes.
Okay. How many times, if you recall, did Pat come with his wife to meet with you? Was it 3?
He came to a visit once. I believe I spoke with him and Lindsay on the phone twice.
Would you agree with me that, as counsel asked, did he get permission to be there? And you indicated no, that you would welcome the third-party contact, right?
Correct.
And did it appear to you that he was very, very invested in her care and was very scared and worried?
Yes.
And he was complaining about the fact that he believed, that they believed, that she was being over-medicated, right?
I believe he was concerned about her symptoms. He felt that they started once she started being medicated initially.
Right, because she indicated that when she first started taking the SSRI back in October, I believe, that she ended up having it increased, and then had a period of almost 2 days where there was no sleep whatsoever. That was one of the instances, right?
Yes.
She also, counsel had asked you, and you did not recall her saying horrible, intrusive thoughts. So if you would just look at November 30th patient message. It says, "Hi, Rebecca." And then it begins, "I don't expect you to answer this until Monday."
I see that.
Okay. And then she says how she basically only slept for about 4 hours at the beginning of the night, 9:30, and then dozed off for 45 minutes and said, "Today, all day, I had horrible, intrusive thoughts and deeply depressed," right?
Yes.
So when was the next time that you saw her after she sent that message on November 30th?
I would have seen her on December 6th. She had sent this message, I believe, on December 3rd, and I saw her on the 6th.
So on December 3rd, and again, it would be the way that they print this thing out, it has a date of November 30th, but then underneath it, it would be a different date of December 3rd. Is that right?
Yes.
Okay. And when you, as an invested nurse practitioner, receive a message from a woman who is postpartum, who has been through what she's been through and the symptomology that she explained and the doctors that she's seen, not two very good results, you'd be concerned when you see a person saying, "I have horrible intrusive thoughts," right?
Yes.
All right. So as a result of seeing on December 3rd that Lindsay Clancy, with her history, had been telling you that she had horrible intrusive thoughts, what did you do? Did you call her?
She had told me that she took the Ativan and now the thoughts were gone and she had felt good.
So.
But I did speak to her about it.
Yeah, but she told you
At her
that
next appointment.
she told you that in her message.
Right.
That she had today, all day, I had horrible intrusive thoughts. Deeply depressed. I finally took 0.5 of Ativan at 6 p.m. And the thoughts are gone, is what she told you, right?
Yes.
Did you ever bother to ask? I don't know. I mean, would you ask the patient what the horrible intrusive thoughts were?
I would have, yes.
Did you?
Yes.
What did she say?
She described them as thoughts of not wanting to be here.
How about, did she ever describe to you that she was hearing voices?
No.
How many people have you treated for postpartum psychosis?
5.
And of those 5 people, did they hear voices?
Not all of them.
How about some of them?
Some of them.
And that's a real thing, isn't it?
Yes.
And visual hallucinations likewise?
Not all.
So with the voices, that would be an auditory hallucination.
Yes.
Visual hallucination, not all, but some.
Yes.
And that's a real thing.
Yes.
So when she had horrible intrusive thoughts, did she say where these happened? Like, was she in the yard? Was she in her car? Did you ask her where and what? Or was it just that she just didn't want to be here anymore?
It was more that she didn't want to be here anymore.
Okay, did you ask her what that meant?
I did ask her if she had any plans or intent for suicide, which changed at different times during our treatment.
So on December 2nd, you have received you sent a note to Lindsay and said it, meaning what she was telling you in a prior communication, it sounds more like depression than side effects. That would be of drugs, right?
Correct.
It is not uncommon for me to hear, and then you quote, "I have never felt anything like this before," end quote, or quote, "I just don't feel like myself." All of this sounds like postpartum depression. Is that correct?
Correct.
You know, sitting there listening to half of this, she's probably crying like half in relief of finally being fucking heard, only it's too late. Like, if only somebody would have heard me when I was screaming for help. Right? Imagine how she feels, having a psychotic break, having unalived your children, your husband manipulated and drugged you more than likely, and all you wanted to be was a mom. And you worked in labor and delivery. Just imagine if this happened to Jen Hamilton. Let me just say that.
All right. So she was expressing all of the symptomology of depression, what you believe would have been side effects, and you indicated that at this point, while you're working through it, this sounds like postpartum depression, right?
Correct.
And what would the symptomology of, what does postpartum depression mean, and what is its effect on a patient?
What does it take to get diagnosed with it?
Postpartum depression is like depression at any time during a patient's life. However, there are some unique considerations. It typically occurs in the first 3 months after a person has a baby, but it can happen at any point in the first year. The considerations that are a little bit different than regular major depressive disorder are that there are significant hormone fluctuations that a person undergoes when they deliver a baby. Sometimes they breastfeed and they wean from breastfeeding, and that can set off additional hormone shifts. And it tends to be a very anxious presentation. And obsessive thoughts can occur with greater regularity in postpartum depression than they would with major depression outside of the postpartum period.
So as a result of this information, you prescribed medication to her?
After I sent her the information on the postpartum, would this still be December 2nd?
Looking at the form that you have, it would be, yes, but I don't know if it's another date that there's a message underneath it. So let's look at the record where it says that on December 7th.
7th,
Yes.
okay.
Okay. And that's where you talked about bipolar spectrum disorder, right?
Yes.
And that's where you talked about how people would have these feelings of goal-directed activity, overly talkative, racing thoughts, need for sleep, things of that nature, right?
Yes.
What was the end result of that? Did you prescribe medication for her?
I did.
And what was it?
Seroquel.
One of the things that you had mentioned is that you provided a mood chart, I think. Is that what you said, a mood chart? Is this it? Is that an indication just so the jurors know that it's in the records? It's a horrible film.
That looks accurate, yes.
Yeah. Yeah, there it is, right there. See on the very top it says mood chart? To the left?
Yes.
All right, and on the top it says daily mood chart. And then you also provided another chart on that date. What is that? That's another variation of it?
It's the weekly mood chart.
Okay. So did you tell her to fill this out?
I suggested that she fill it out so we could keep track of her symptoms.
Okay. Do you remember if she filled it out when she spoke to you?
She did not speak to me about filling it out. After that, she did say she printed it out.
Okay. Did you ever ask to see it?
I don't recall.
Okay. On December 1st, you met with her, is that right? Oh, no, wait a minute. Christine Zappi. Who's Christina Zappi?
I believe she's also someone that works at South Shore Medical Center.
All right. Do you know that she saw Christine Zappi on December 1st? Christina. I'm sorry. It says Christina.
I'm not sure if she saw her for a visit that day.
Okay. Have you seen in the pool of records that you have that she did see this individual and noted that she had been dealing with the problems, the insomnia symptomology, for over a month and a half, and medications keep changing, and it doesn't seem like much is helping. Did you ever see that?
That does sound familiar.
Okay, so she was somewhat in, this is almost hand in glove with saying, I'm not being hurt, right? Same
Yes.
idea? Did you see her on December 2nd, the next day?
I spoke to her on December 2nd.
Okay. And again, the district attorney kept asking you about, she had the opportunity to come in and see you if she wanted to, and things of that nature, right?
Yes.
And would you agree with me that it's sometimes better to have a face-to-face actual meeting with a patient rather than just on the computer?
Yes.
Did you ever, if you recall, with all of the symptomology and deterioration going by week after week, say to her, I really think that we should get together in person?
Yes. So we met in person on the 6th, and our plan had been to meet in person on the 13th.
Okay, so that would be December 6th, correct?
Mm-hmm. Yes.
Now, December 2nd, you had a conversation with her on the phone, is that right?
I believe it was just my chart messages.
Okay, so you see on where it says, again, it's got the big black letters, December 2nd, 22, and then underneath it, it says behavioral health history. Can you find that on your records? If you don't, that's fine. That would be the time that she indicated that she had been to the ER for anxiety symptoms as well as insomnia and heart palpitations. You remember that?
I don't see that.
Okay, well, then let's get it. Do you have access to other staff notes and records, right?
I do. I only brought my own.
Okay,
Me.
that
Yeah.
answers that. So if I approach you,
Yes.
Can I see what you're showing her first? Sorry.
sure. Yeah. Latasha Dukes. Who's Latasha Dukes?
Letitia Dukes was a clinician at our program at the time.
All right. So am I looking at Latisha Dukes, MSW? What does that mean?
Master of Social Work.
All right. And does that indicate a date that Ms. Dukes saw Lindsay?
December 2nd.
All right. And on December 2nd, again, she was complaining of symptomology, she meaning Lindsay, having heart palpitations, right?
She's describing that she had heart palpitations and she went to the ER for anxiety symptoms.
Okay, so the answer is yes.
Yes.
Okay, so
Yes.
and that she then went to the ER, and per a patient's report, she has an addiction to Ativan, and that's why she can't sleep. And she also noted had weight loss, right?
Correct.
And panic attacks, right?
Correct.
So she's got a fear that she's on the benzodiazepines by script that she didn't want to be on, and she couldn't sleep, and she was losing weight, and all the other symptomology that we talked about, right?
Correct.
And that's in December.
Yes.
December 5, Nicole Hayden-Francis had a chance to speak with Lindsay. And at that point, there was a recommendation that she might want to try INPT LOC. What does that mean?
Inpatient level of care.
Okay. And that would be Nicole Hayden-Francis, who's a nurse, was telling her that on December 5?
Yes.
Now, and again, I know you don't have the records from Letitia Dukes, so if I may approach.
Like, what was their goals of care for the patient? I can understand why this woman was like practically beating her head against the fucking wall. Like, what is what is she supposed to do? Hopes and dreams? Because that's all she's really been offered in pharmaceuticals. Multiple, mixed.
You may.
On December 5, you correct me if I'm reading these wrong, this would be Letitia Dukes, December 5, right?
Correct.
Okay. And on that occasion, Letitia Dukes notes that she called Aspire Crisis Support, she meaning Lindsay, right?
Yes.
What is Aspire Crisis Support?
Aspire is the community mental health program that operates the local 24-hour emergency services program for psychiatric emergency services.
Okay. So when I say you collectively, I mean psychiatrists, nurse practitioners, RNs in the psychiatric world, tell patients that are in crisis that if you feel that you're going to have suicidal ideation or anything, that you should call these numbers is what your people will give them, right?
Yes.
She called Aspire Crisis Support, not once but twice, right? If you know.
I'm aware of the one time she called.
Okay. But she was not given any help at all by Aspire, whoever they are, right?
I'm not aware of that.
Well, it says right in the records from Letitia that she met with an Aspire clinician virtually and was told that she did not meet the criteria for inpatient treatment due to not having an SI plan. What does that mean? They just told her you're not laying on the ground with your throat cut, so we're not going to be able to help you?
Can't speak to what they told her.
So Aspire then recommended that she start or go to a day program. Is that correct?
That's correct.
And the clinician said that he, from Aspire, would be sending the patient resources, right?
Correct.
But they never did they? If you know.
I don't know.
Further, Letitia notes that they reviewed the sleep hygiene with the patient. Clinician provided patient suggestions for meditation, grounding, self-soothing techniques. What's a self-soothing technique? You know.
It might just be simple strategies to soothe yourself using any of your five senses.
And she notes, and again, this is on December 5th, that Pat, patient's husband, joined the visit, reporting that her anxiety had become significantly worse since starting the psychiatric medications. Did that say that? Anybody?
That is what that says.
Okay. And in fact, when you spoke to Pat, he had told you that, in his quotation, his words would be, it was 10,000 times worse since she started this medication, right? If you know.
I don't recall him using that phrase.
But he was upset about the medication, wasn't he?
I would say he was concerned.
Do you recall that he said that you're turning her?
The problem is Pat. He doesn't. None of this makes clinical fucking sense. To any healthcare provider, they're baffled, right? They're using their resources. They just got this patient. Okay, let's just kind of put this into perspective. This is not an established patient. This lady comes out of the fucking blue. She's got all these goddamn problems, and we're trying to figure it out, right? And that she's doing her damn job. This one, that one, kinda. There's room for improvement, but it doesn't make clinical fucking sense. You're having these weird reactions one time to Zoloft? Are you allergic to it? You was on shit in the past during nursing school, like, so now, like, how long were her and Pat married is another question I have. How long has he really known her? Because if this were me and I'm sitting here as a clinician and I'm listening to this reaction, like if somebody was reacting this way to like my respiratory meds, I'd be like, what? Some of them I would get because they're absorbed in the lung and they put shit in there that is agitating. Like I would start to question things. This is so weird.
You're into a zombie?
I do not recall that he said that.
So would you say to the jury that he was concerned or he was pissed off about the medication and what it was doing to his wife?
Objection, hasn't been answered.
No, overall.
I would say he was concerned.
Concerned? Okay. Did anybody address his concerns?
That day,
Any day?
I would say that day, I collaborated with them to take her off certain medications.
Okay.
Who did you talk to? You don't talk to nobody. None of you do. Did you collaborate by just not prescribing her nothing no more? Because she told you? The hospital couldn't get fucking a hold of you.
December 6th, you had a meeting with her, is that correct?
Correct.
Again, she's diagnosed postpartum anxiety, right?
Correct.
Her EPDS score, as a result of being administered, the Edinburgh test was at that time a 21, right? That would be underneath office visit and perinatal behavioral health, above assessment and recommendations.
Correct.
And 21, how would you grade that?
Severe.
Severe what?
Severe signs of postpartum depression.
So you know that she had lost over 15 pounds by that point?
I was aware she had lost some weight. I was not aware that it was 15 pounds.
Okay. So then there was another patient message on December 7th where she again was expressing concern about the drugs, and you indicated, either way, I continue to recommend the Valium taper, right?
Correct.
There was a period of time that she indicated that she wanted to get off the medication and get off the drugs, and you indicated, as you told us, that you were on vacation that week, right?
Yes.
You basically told her to tough it out and just hit me up when I come back from vacation, right?
No.
Did you tell her to call you when you came back from vacation?
No, I asked that she try to hold off and wait for me to come back from vacation for the taper. She had wanted to taper it sooner.
All right. Do you have somebody that covers for you if you're on vacation?
Yes.
Did somebody cover?
She said that she was going to follow up with her other psychiatrist for the taper, but she did reach out to our program while I was on vacation.
Sorry, I couldn't understand you.
I'm sorry. I know that she said that she had an appointment with her psychiatrist who would do work on the taper with her. And I do know that she was in contact with other providers at our program, including Letitia Dukes, while I was on vacation.
And Letitia Dukes is a social worker, is that right?
Yes.
Okay. December 9th, there was another telephone encounter, it's called, right?
Yes.
And yet again, her husband, Pat, was involved with this call, right?
Yes.
So does this put Patrick up to around 4 times, maybe 5 times, that he had been involved either in person with your business or on the telephone or on the telemetry or whatever it is, computer?
I spoke with him on the phone twice. He was in one of our visits on December 6th, and it appears he was in the visit with Letitia as well.
So this would be a Rebecca Jollotta telephone
Yes.
encounter on December 9th, right?
Correct.
And on that occasion, Lindsay, and it says, and her husband called this writer, that'd be you, right?
Correct.
Regarding the plan to taper, correct?
Correct.
And they both agreed that Lindsay's symptoms remain too acute. What does that mean? What's acute mean?
Severe.
Did they say that she's sleeping but waking up? Let me back up. Was he telling you all of this while she sat there? She wasn't saying much in that conversation, was she?
That's not what acute means. It means like immediate, like now. I need help now. Not emergency, but I do need immediate assistance. Like yellow, caution.
I don't recall who was saying more than the other person.
Do you recall that she indicated that she wanted her husband to be involved to speak for her because she was really decompensating, right? She wasn't self-reporting.
Now, in that case, was she suffering an acute psychiatric crisis? Yes. It's not a chronic, persistent, established condition. It was an acute mental health crisis requiring immediate care, which she apparently has to continue to beg to receive, like every woman.
Self-advocating too well for herself at that point, was she?
I just know she did have her husband on the call, and he did speak on the call.
They indicated that she was waking up with panic symptoms, right?
Correct.
What panic symptoms? What does that mean?
Panic symptoms can be this sudden rush of intense.
That's not what can be. What did she tell you, or what did her husband tell you? Her
Panic symptoms. Panic symptoms.
What were they?
Panic symptoms are racing heart.
There's a long list of symptoms for panic. You didn't chart any? There's not a checklist that justifies your use of the Valium? Why is my next question. It's always my question.
Intense fear. Those are panic symptoms. Sudden rushes of intense anxiety that seem to come out of nowhere.
Okay. Is that something that you learn in school, or is that in a book? Is it in the DSM, or what? So we all have our own opinion as to what panic symptoms might be, but from a medical standpoint.
Those are what panic symptoms are.
Would you agree that Patrick, in this conversation, also indicated that she was having intrusive thoughts, yet again? Right?
Correct.
What were the intrusive thoughts that she was having when she wakes up with panic symptoms?
I don't recall the specific intrusive thoughts. I recall asking about safety and that she did identify having thoughts of suicide.
Well, Patrick told you that she has thoughts of suicide, right?
Lindsay as well.
Okay, so I'm asking you what you, as an invested healthcare provider, told this woman to advise her, what your investigation revealed. If you have a patient tell you, I'm having intrusive thoughts, what were they?
I recall that they were intrusive suicidal thoughts.
And is this a frequent theme that you noted?
I don't know if it was a frequent theme that I noted, but I know that it was documented several times throughout her course of treatment with providers in my program.
So at this point, with all the providers of your program and her indications, as well as her husband's, about the number of times that she had suicidal ideation, did you prescribe more drugs for her?
At this occasion, I prescribed Valium.
You bumped her up to Seroquel to 400 milligrams, didn't you?
Yes.
Did that help? How'd that work out?
At 200 milligrams, she was able to sleep. So I felt that the manic symptoms in her mixed presentation were alleviated at 200.
So on December 12th, she sent you one of those messages. Thank you, Rebecca. December 12th. She says, for the last 3 nights, I've taken 2.5 milligrams of Valium and 200 of Seroquel. I have to say, I do like the way it makes me sleep deeply and soundly for about 7 or 8 hours. I don't like the way I feel in the morning. You read that to the jury for the DA, right?
Yes.
But then the rest of the sentence is, incredibly depressed, and unmotivated to do anything at all. Do you remember her saying that?
Yes.
Now, you'd agree with me that that's one of the observations that you make or symptomology of a person that's suffering significantly from postpartum anxiety, depression. She's incredibly depressed and unmotivated to do anything, right? What
Correct.
does that mean? What does she mean by that?
I'm not sure I understand the question.
When she says that she's unmotivated and is incredibly depressed, was she able to go shopping? Could she get in the car and drive? Did you know that she stopped driving?
I was not aware of that.
On December 12th, she saw Letitia Dukes. Patients reporting thoughts of SI, suicidal ideation, but no plan. She contacted Crisis over the weekend and will be starting a PHP in Norwell. What does that mean?
Partial hospitalization program?
Okay, and that's because, yet again, she's reporting the suicidal ideation, correct?
Correct.
And there's a difference between suicidal ideation and having thoughts of suicide, right? Under the DSM, is there?
There's a suicidal ideation can be a spectrum.
Okay. On December 13th, telemedicine in the perinatal behavioral unit. Again, there was a concern about suicidal ideation, and her look underneath Edinburgh postnatal depression scale, if you have it, was now 20. It's still severe, right?
Correct.
So what did you do on that date, if you know, December 13th?
I recommended that she continue Seroquel 200 milligrams and Valium 2 milligrams.
December 19th, telemedicine with Letitia Dukes. And this is when she indicated that she was going to contact women and infants, and Letitia helped her out to do that. So she went to women and infants on the 20th, right?
Correct.
Okay. So as time went on, and she had gone to women and infants and was unable to be treated on December 20th and went home, or picked up by her husband, what was her course of treatment after that? You didn't talk to anybody at Women and Infants, right?
At that time, I did not talk to anybody at Women and Infants, but I do know that we re-referred her in a few days.
I know you already told us you re-referred her. My question is real simple, and I don't mean to be bully. I just want to ask you.
Yes.
Did you talk to anyone at Women and Infants?
No.
So, as I read the record, which is an exhibit, Women and Infants, December 20th, differential diagnosis, concern about medications, reaches out to Rebecca Jollotta, no return call from Jollotta. You don't recall that. You don't know what happened to her after that, do you? Other than going to McLean.
I know that she went to McLean.
Right. Do you know when she went into McLean?
At the end of December, early January.
Okay. Did you review the McLean records? Because you have access to them, right?
I do not have access to them.
You don't?
I don't.
So if you're treating a person for all of the stuff that we've talked about, and it's now apparent that things have decompensated so bad that they have voluntarily admitted her to a locked ward in a mental institution, is it important to Rebecca Jollotta to find out what the diagnosis and treatment was of their patient?
Yes.
Did you find out?
I did not.
And any time you called in an ROI, any time you needed a release of information, such as a HIPAA release, she would have signed it, right?
Action.
Overrule.
Would have.
You have no reason,
Speculation.
well, not hardly.
All right, I'm going to allow that. The jury can weigh that. You can explore that on a cross-examination. Redirect, I'm sorry.
From your treatment of Lindsay and her efforts to be a good patient and tell you all what her symptoms were and third-party contacts and everything, to your opinion, she would have signed a release for you to get access to pretty much anything you wanted, right?
I'm not sure if she signed a release for McLean to be able to speak with us.
Did anybody ask her? Did you ever ask her to sign a release?
I did not.
That's all I have, Your Honor.
All right, Attorney Buckingham?
Ms. Jollotta, Lindsay Clancy was only a patient at the South Shore Perinatal Behavioral Health Clinic between November 20th and December 13th. Fair to say? Meaning November 20th is the first contact she had with Julie Paul, right?
Yes.
And December 13th is the last time that you met with her.
Yes.
And she came to that clinic not from a referral from somebody like Jennifer Tufts, correct?
Correct.
And so your information about her contact with that psychiatrist is limited to what she shared with you.
Correct.
And she never offered to you that maybe you should talk to her, did she?
Correct.
Now, you've also been asked about providing all the different medications. And if I may approach with Exhibit 1, please.
Yes, you may.
I'm going to show you the second page there. I know it's kind of small, but take your time to take a look at it. Do you ever see on there that you prescribed any medications to Lindsay Clancy in January of 2023?
None.
And in fact, January 12th of 2023 is Jennifer Tufts, correct?
Correct.
January 5th of 2023, Aaliyah Goodhart, correct?
Correct.
January 16th, Jennifer Tufts.
Correct.
Jennifer Tufts for diazepam. Jennifer Tufts for diazepam. So your last prescription filled is December 22nd, 2022.
Correct.
So when counsel asked you about this chart he was reading from,
Yes.
you would agree with me that this record from CVS is what you would generally see when you pull a patient's prescription lists.
Yes.
And as far as the going back through some of the medications, and you were read by counsel about on December 6th and 7th prescribing the same medication, is it common that you would change prescriptions to adjust for dosage?
Yes.
And when you start some new medications, do you give somebody an automatic 30-day supply if you're not sure if that's going to be the course of medication?
Correct.
So sometimes you're prescribing things at kind of odd dosages, right? Or odd number of pills.
Yes.
So on December 6th for the diazepam, you actually prescribed 1 pill.
Yes.
And then December 7th, 2 pills.
Yes.
And then December 9th, a 5 milligram dose, 8 pills.
Yes.
And then on December 30th, I think it is, 2 milligram dose, 7 pills.
Yes.
And then the Seroquel as well. On November 30th, when you first prescribed that at that low 25 milligram dose for insomnia, she was given 30 pills.
Yes.
And then when you changed the plan as of December 7th, you had to give her a new prescription for a higher dose, didn't you?
Yes.
So that's the 100 milligrams at 22 pills.
Correct.
Now, when you adjust the dosages or adjust the number of pills, do you give specific instructions on how to take the medication going forward?
Yes.
Do you expect the patient to follow those instructions and disregard the previous prescriptions?
Yes.
Now, at several points, you've indicated and counsel asked you about referrals or recommendations that Ms. Clancy go to a partial hospitalization program, right? Do you recall that line of questioning?
I do.
And does South Shore Perinatal Behavioral Health have a partial hospitalization program?
Not at this time.
And so oftentimes you have to pair or recommend places outside in other communities, correct?
Correct.
And you've talked about women and infants, and that's one of the places that you've referred, and that you did in fact refer this patient, correct?
Yes.
You don't have an affiliation with women and infants, do you?
No.
So any information that you receive would have to come from the patient or at the patient's request. Is that fair to say?
That's fair to say.
In regards to her visit to women and infants in December 20th, you had contact with Lindsay Clancy the next day, didn't you?
I did.
And that was through the MyChart messaging?
Yes.
And she explained to you what happened at Women and Infants?
Yes.
She gave you details about what they told her, that she wasn't going to benefit from the groups, and that when she told them about her medication history or medication issues, that they believed that she should come off Seroquel.
Yes.
So while you don't have the records of the diagnosis, you had a report from the patient about what they were recommending, didn't you?
Yes.
And as a result of that, you started a conversation with her about tapering Seroquel, didn't you?
Yes.
Council bounced around a little bit with the dates, but as far as some of the communications and contact with her, in December or November 30th into December 1st, were you talking to her about postpartum depression?
Let me double check, please.
Mm-hmm.
I was.
So that's when you sent the information in the mood chart, right?
Yes.
So that's November 30th, December 1st. And now by the time you get to December 7th, after having pretty significant back and forth communication with her, now you're talking with her and giving her some information about bipolar, correct?
Correct.
So upon her presentation at the clinic and her initial focus of treatment, it was for postpartum depression and anxiety, was it not?
Yes.
And as you began to have more contact with her, as you began to trial different medication regimens, is that when your differential diagnosis started to emerge?
Yes.
And you responded to that appropriately with the medication you recommended, right?
Yes.
That's why the titrating of Seroquel became a conversation, is that fair to say?
Yes.
And when you, after the Women and Infants program on December 20th, you didn't see Lindsay Clancy again in the clinic, did you? Either telehealth or in person?
No.
And the only contact you had with her was through the messages about the plan for tapering, correct?
Correct.
And while you were going to be away and not available to her, you still gave her a plan and a prescription to assist with tapering, didn't you?
I did.
Was your clinic or your colleagues still available for her if she needed it?
Yes.
Did she reach out?
I believe that either she or Patrick did reach out on December 30th.
And that was for a higher level of care recommendations, right?
Correct.
But as far as issues with the taper, did she reach out to you or your colleagues about issues with the taper?
No.
Now, counsel went through with you a call in which Patrick and Lindsay, or Lindsay indicated to you that she was having panic symptoms and intrusive thoughts. Do you recall that?
Yes.
In that call, did you contract for safety?
Yes.
What does that mean?
It means assessing immediate safety. For example, not to speak in hypothetical, but if somebody was saying, I have a plan to kill myself, I have a knife, I am calling 911, I am sectioning that person. If somebody's saying, I'm having thoughts of suicide, okay, what are they? Do you have a plan? Do you have intent? What I recall from Lindsay is she was having thoughts of suicide. She did not disclose a plan, no intent, and her husband was aware of this as well. He was on the call.
In fact, in any of the times that you met with or had messages with Lindsay Clancy and she talked about intrusive thoughts or suicidal thoughts, did she ever articulate that she ever had a plan?
No.
Or that she ever actually had any intent of completing the act?
No.
And you're aware that she did have support in the way of her husband and her family, didn't you?
I was aware of that.
And again, intrusive thoughts, when a person tells you, a postpartum mom tells you they're having intrusive thoughts in your training experience, in the times that you've treated moms with postpartum depression or anxiety or even psychosis, that's a fairly common complaint, right?
Yes.
And again, the depressed and unmotivated, fairly common to hear those from new moms.
Yes.
And in your experience in treating individuals with postpartum psychosis, whether they hear voices or not, did you ever have any concerns based on your contact with Lindsay Clancy that she was suffering from postpartum psychosis?
I did not.
I have nothing further.
Well, it appears as though she was, doesn't it?
Objection.
Hold on. Why don't we do this? Why don't you get over there, Mr. Barrington, if you can, go ahead. Let me ask you a question.
I will try.
All right. Anything further? All right. You can step down. Thank you.
Thank you.
All right. Counsel, could I see you over? Sidebar.
How about you getting hand slapped? We're all sitting here speechless, and studio's telling me no sound detected. Check your microphone, because we're all fucking captivated here. I think this might be the end of it. Yeah, there's like 3 minutes left. They're probably going to end. And I'll reset. That way I can keep track of what the fuck I'm doing. Let's see here.
Schedule. So just for purposes, I don't want to jinx us, but that's kind of where we are.
Where are we at? This thing doesn't move the way.
We're going to break for the day at this point. And so what I'm going to ask you to do is come back tomorrow at 9 o'clock. The hope would be kind of a similar schedule that we could follow tomorrow as well. And then I'm told that we are well on schedule.
Yeah, I don't know how much I'll listen to. Is there a lot of...
schedule. So just for purposes,
go ask
I don't want to jinx us, but that's kind of where we are. So I'm going to excuse you till tomorrow. Remember those instructions. Don't read anything about this case or any similar cases Don't do any research, don't talk about anything, don't take any field trips, don't happen to be driving by any certain places, and put this out of your head till tomorrow, all right? It's been a long day, I appreciate it, so I hope you have a nice evening, and come back here tomorrow morning. We'll pretty much follow the same type schedule. So again, my thanks, I hope you have a great evening, and we'll see you tomorrow.
Court, all rise. Good. Close the notebook, please. Wait.
Members have exited the courtroom. This court's in
So
session.
I'll probably listen to the
Counsel,
mental
anything
health
we need to address
clinician.
before we recess till tomorrow?
No, thank you.
All right, so this court will be in recess on this case till tomorrow, 9 o'clock. Thank you.
Court, all rise.
So let's pause this here. So looking at what they have to say here, because it was the mental health clinician, the state police, and the ME. I don't want to listen to the ME. I do not want to. I don't. Sorry, I'm just kind of reading. I know it's boring and silent. Give me just a second. Okay, yeah, let's go to day 12 for right now. I'll download that when I start playing it and put it in Discord. Just a second. Let's back it up. So, oh shit, day 13 is live right now. I don't want to watch it live. It's easier for me not to be fucking surprised. Stay unemotionally invested. It's just, you guys are more than welcome, but it's easier for me to go back. For me, but it is live, it looks like. I'm not looking for
This court is
their.
now in session. Please be
Oh, it's
seated.
a short. It's not too bad. It's only 3 hours compared to all the other testimony. I'm not looking for the same thing that everybody else is out of this. I have a lot of topics that I cover, but there are ones that are like near and dear to my heart, and I'm going to stay in my fucking lane. I want to delete that. Get rid of it. So that's where I'm at. I'm not trying to stay up to date with the case. I have a certain eye that I'm looking at, and I'm trying to stay on that because I want to write and do other content with it. Yeah, I will not watch the ME or any of that trauma. Like, I'm good. That's why I like going back. I have my buddy ChatGPT to keep me emotionally uninvested and detached from all this because I learned my lesson with Rebecca Park. Right. We're good there. Don't like surprises. So I can maintain my emotional distance with this. And that's how I prefer to keep a rational, calm thinking mind. Yeah, it is. Yeah. And I appreciate that because you guys know me well enough to know, yeah, no, RT don't like that shit. It's not about the murder mystery for me. It's just not. It's just, no. Mm-mm. So, yeah. Okay. So I'm going to work on downloading that and I'll put this cheat sheet in there so people can do the same thing I'm doing and try to avoid shit. Unless they're just engrossed. I have learned there are some things that people should just stay wondering. You usually regret wanting to know the answer.
Good morning, Your Honor. May I proceed?
Yes, please.
Your Honor, before the court, we have the matter of Commonwealth versus Lindsay Clancy. Ms. Clancy is present. She is represented by Attorney Kevin Reddington, and the Commonwealth is represented by Assistant District Attorney Jennifer Sprague and Assistant District Attorney Shannon Buckingham.
All right, well, good morning, everyone, and good morning, counsel.
Morning.
Good morning, Ms. Clancy. All right, so before we get going, let me talk to counsel about today's schedule and kind of where we go. So if I could see everybody at sidebar, please. So we're set for the jury at this point.